आप जिसका बोलो सर, मैंने दोनों का ओपन करके रखा। ठीक है। હમ. ના ભાઈ ના, કોઈ પાછું નથી અપાવવાનું, એ જોડે જ લઈ જવાનું હોય. ओके सर, रनिंग परफेक्टली. हाँ वो में हो जाएगा, डोंट वरी. हो गया. आपको वो लिंक करना है ना, वो लिंक में कर देता हूँ. आओ आओ मैडम. आओ मैडम. મજામાં? કોણ છે તો તને? તું સીધી પણ અહીં બાય કઈ જતી રહી તો હું શું કરું? चालू करी बस। चालू છે screen is sharing. હજી ભાઈ બધાને બોલાવી લે. હા બધા કઈ એ કામ કે એક બે મિનિટમાં ચાલુ કરીએ છીએ આઈડી.
Hello, we are starting session in 5 minutes.
ના ના એ ત્યાંથી અહીંયા લિંક અપ છે ને એટલે I request our all delegates to come for the post lunch session. એ મિનિટ પછી કરીએ. રાત સર ને હા એકવાર બધાને રાત સર જો આવી જાય ને પછી એકવાર ચાલુ કર. રાત સર તો રાત સર કહી દઉં. Welcome back to all. Now let us begin our post lunch session. The next lecture is to be presented by Sudhir Agrawal sir, who is a group director, Communication Technology and Application Space Application Center SAC, and he is having vast experience of satellite communication and navigation. So I request Sudhir Agrawal sir to hold the dice.
Thank you, sir. A difficult session after lunch, thin attendance, maybe the drowsy people. But anyway, let us go ahead. So today we'll look into the ISRO's telemedicine. What we have done. Battery cut down. खाना नहीं आ- Disconnected. सभी
हाँ
इसका बाकी सब बढ़िया. So you see, ISRO's telemedicine started in 2001, but this is a step. Actually, before that, also in 90s, we started with telemedicine. See, generally, whenever we start at ISRO any project, the direct funding will not come. We have to go into the steps. Maybe we will do one step, one POC with one terminal, and then maybe few number of more terminals. And then once we get a success, then only the fundings will come. So officially, if you see, the pilot project was started in 2001. Before that, the POCs have been done in 90s. So I compliment all the pioneers, Dr. A.K. Sangal, Ravi Saxena, who have started this in the late 90s. And this model was then later on adopted by the Karnataka, Rajasthan, Odisha, Madhya Pradesh, and Maharashtra. Later on, because the defense forces, their nodes are in the hinterlands, in the remote locations. Maybe it's glaciers, the northeast regions, Andaman regions, the Lakshadweep. So they adopted this model also, and still they are continuing. So presently there are 195, this is a typo mistake, there are 195 operational nodes. But we are targeting to achieve this 1000 figure. So that is our aim. So that way this figure is right figure right here. And we are providing the real-time consultations, medical transmission and continuing medical education through this network. You can see how this has been scattered throughout India. All the nodes have been scattered. So this is a network diagram. Right now the hub is at the operational, the telemedicine hub is at Eastrek, Bangalore, and the satellite is CMS1, which is having a 36 megahertz bandwidth. Our forward link is a 7.5 Mbps and return link is 833 kbps, through which we are providing 512 or 1 Mbps of data for a video conferencing. You can see we have a specialist end where generally the video conferencing equipment is there. And on the patient end, there will be the diagnostic equipments which are connected. Maybe it's a patient monitoring, the blood glucose monitoring kind of devices which are connected, which take the data and directly feed it into the network. So I'll just give a brief that where these are installed, some of the installations. If you see, it's in the Leh at the altitude of 16,600 feet. The another one is Sikkim, 15,000 feet. Uttarakhand, 10,000 feet, and Assam, around 5,000 feet. You can see how they are managed. There is a lot of ice also if you see the Leh. Now what happens is generally these locations are inaccessible. So even the persons who want to deploy it there, they're not able to reach that. So what we do is we train the paramedic staffs or the defense staffs to install, to take these terminals from the base camp to install it at the higher altitudes and operate it. So you can see how these are being done. And the bottom figure where the antenna has been put into the tent. So this experiment was carried out because in the snow will get deposited onto the antenna and then we will not be able to get access to the satellite communication. So we tried to put it into the tent and see whether the RF signals are getting blocked. And in the KU band, we were able to successfully transmit it. The another advantage was that this disk was not visible. So that if an enemy is trying to track the installations, then they will not be able to track it. So this was the advantage, a simple experiment, some POC we had done, putting it into the tent. Then one of the societal applications where we have put it into the this Amarnath Yatra. You can see we have a holy cave, Sesnag, Chandanwadi, Baltal, and all these 6 terminals were connected to Kashmir on a DOHS. And every time, whenever this Amarnath Yatra, even this year also, we have installed that. So every year when the Amarnath Yatra takes place, we install it across en route the Amarnath Yatra, this kind of terminals. So the pilgrimage and the other fellows are able to get the benefit of it. These are certain news coverage of the this Amarnath Yatra. We had put it at Baltal, Panchtarni base hospitals. So outcome one fallout of was telemedicine was a CME, continued medical education. Somewhere in 2012, when we had a telemedicine user meet, they said that okay, you are doing this telemedicine, but the consultation is not means we are not continuously using the network. Whenever the requirement is there, we'll be using it for part time. So why not to use it for some other purpose also? And after brainstorming, they said that let us start the CME. That is a continued medical education, because the paramedic staffs which are sitting in the hinterlands or the doctors, junior doctors who are in the base camps, they get educated, they become to the aware of the latest technologies which are occurring here. So the CME was started, and we converted the telemedicine network into a virtual classroom. See, right now all these things, the Zoom and all these things after COVID, we are seeing that it has become a common, but we started somewhere in 2012. If you see 2001, when the telemedicine was started, even the fiber optics, not even your copper line was not carrying the data. There was no mobile network. So at that time, we used to provide 512 kbps of video conferencing. So today, anyway, the fiber optics has come. So CME was conducted in a virtual classroom environment with the participants logging it from the various locations across India, and the different technologies like TDM, MFTDMA are being used. Now to use the telemedicine for a CME, we had to develop a software. That is, we call it as a learning management software. So this was developed and we started using this program. These are some of the glimpses. Even today, see, the commercial internet, when we are talking about the fiber optics, is a prone to disaster. Correct? Whenever the disaster will occur, the network will fall down. While the satellite-based networks will deliver you the high quality dedicated link. It will be always available to you. Even where the inaccessible regions are there, the hinterlands are there, like the glaciers. We talk about northeast regions, Andaman, where there is no connectivity. So all these places, the satellite communication gets connected. Where the fiber optics links are not there, even the mobiles are not working. So in this, we are trying to bridge the gap of the healthcare education, ensuring that the medical professionals, regardless of their location, can access the cutting edge knowledge and the expert guidance. So this is an objective of CME, and you can see the CME photographs, some of the CME live sessions which are being done. Most of the paramilitary forces, paramedics in the paramilitary forces join this. You can see in the bottom, you can see it's at the glacier location. The person is wearing all the gears and he's watching this. These are some of the other pics. Now, talking about the CME consists of the two sessions, two parts, question answer session. And the expert doctor will deliver the presentations from a dedicated studio facility, which will target the students, junior medical doctors or the paramedic staffs, nursing students and all that. And after the lecture session, there will be a question answer session. And again, it is followed by a feedback session. So actually feedback session I have not mentioned here, but there are 3 sessions into this. And if you see, we started somewhere in 2014 and we are continuing every month. Even during the COVID, we have continued this. The 100th session occurred in June 30, 2025. And at that time, Dr. Tejas Patel, the Padma Shri and Padma Bhushan from the Apex Hospital delivered that lecture. At that moment, 88 remote nodes joined it, and around 900 doctors and the paramedic staff joined that network. So this kind of coverage we provided at that point, and almost all the sessions we are doing that. Last week only we conducted 109th CME session. So the next will be 110 next month in April. Some pictures, if you can see, the first session is in 2013. I've taken this pictures every year, 2014, 15, 16, Virendra Kumar sir, who added this at that time is here. 17, then 21, then some of the latest 2025, 102, 3, 5, 6. So it's all continuing. Apart from this CME, we have now developed a ISRO telemedicine portal, which will give you all the information you can see when the next session is going to come or how many consultations are going on, when the next CME is going to come, and all the past CME if someone wants to see, that also is possible. You can see the CME videos, that is 100 plus, are shown over here. So even someone wants to refer to them, it's possible to refer to them. Apart from that, one into this is a multi-party conference. So we have added a multi-party conference which we do it one day after the CME. But now we are incorporating into this, so that not at the same moment they can fill in the feedback session after the lecture session. So this is a part of telemedicine. So what is the present or what are the new things we are looking into? Right now, if you see, we have around 200 nodes, and most of our requirement has shrunk because of the fibers, terrestrial networks, which are becoming more popular. But still, the defense and the paramilitary forces are using them. Now, recent they had a requirement, the IDS, Integrated Defense Service, that we don't want a fixed terminals. We want a terminals on the move, or terminals which can be on the pause, so that no, they can go into the war zones if required. Right now, they are stationed at a particular base stations or at the nodes, but if they have to go to the war zone, then the mobility is required. And the terminals need to move. They should not become a sitting duck for the enemies, because the antennas are bigger, around 1 meter antenna is there. So if it is means from the space, if you look, they become like a sitting duck. The enemies can bombard it. So they wanted something like on move. So we did a POC, if you can see in the left. Right now it's in a better shape. So again, we have to go through two, 3 iterations to achieve this. The middle one is a SATCOM on the post. It is a 1.2 meter antenna. The earlier one is a 0.6 meter antenna. It's like a DTH antenna only. Correct? And to test this, see, every time you cannot put it onto the vehicle and test it. So to test and simulate the vehicle environment, we are using a 3-axis motion simulator, which is shown on the right. Apart from that, what I am looking is like, no, suppose if you have seen Jurassic Park 3, when a team of soldiers goes to fight a dinosaur, the entire screen, you can see their status, the soldier status there, what is their heart rate, what is their breathing and all that. So similar kind of wearables if you can make for the soldiers. And that information if can be transmitted tele. So on the screen itself, we will be able to see. So they have dreamt it, they have dreamed, we have to now implement. So I request whoever the startups are here, they can join us to implement all these things. So that is one wearable things we are talking about. Another thing is a telesurgery. We were discussing, but telesurgery right now requires a high data rate of around 40 Mbps, correct? And a very low latency, 200 millisecond. Now, ISRO doesn't have a low altitude satellites, LEO satellites, and we have mostly geo satellites, and the latency is around 500 millisecond. The data rates are very limited, maybe 5 Mbps or up to 10 Mbps we can go. So how to achieve that? Because till now in India, no one has done a telesurgery using SATCOM. We want to do a POC. So I request TSI to join into us to do this. Because we are a platform providers, but the technology, the medicine part, the surgery portion, and all that has to be done by the doctors only. So TSI has that expertise and we can provide, but yes, whatever are the latency and bandwidth, that we have to somehow come down and achieve. I was talking to Dr. Haribhakti. He said that why not to start? Either we can do telesurgery using a humanoid, on a humanoid, just to understand that how the latencies are working. So something like that we can go ahead. or maybe something like nursing using a robotics if you can do. So these are the fields which we are looking into it. In November, we had a TSI meeting at Bangalore. So someone asked that ISRO pioneered telemedicine. So what next? Because telemedicine is now taken over by the private players, and as the government policy is that whatever the technology ISRO has developed, let it percolate down to the industry, let them take it up for the commercial use. So we said that the future is a space medicine. Correct. So that is what the ISRO is now looking into. Now, if you see, there are a number of, I have not covered everything into the space medicine. One is like a molecule bounding. How in a microgravity the molecule will bound for a medicines, for the drugs. So can we use some sort of binding which can help us in a microgravity? Maybe if some compounds we can send it to the space, do a binding, bring it back, and use it as a medicine on the earth. If that has advantage, that is the one field. The another field is the crop cultivation, because the long planetary missions will be there, or even the International Space Station. So how if you can grow the crop on it? Now you see, one will say, what is so in growing a crop on an International Space Station? But when you put a seed for a germination, where the roots will grow, because they will not find a direction. There is no gravity. Where the stem, the leaves will come out. So all that experiments will have to be done, and the environment is controlled. In a natural environment, Earth atmosphere, we know it will have some sort of a nitrogen, some sort of carbon dioxide, oxygen. It's all taking care. But in all these missions, the air is totally controlled. So how the crops will behave in this? So that is another field where we are looking into it. You can see the different gravity. Earth has a 1 g. Mars has around 1/6 G. Moon has still less, 3/8. ISS is in a micro. So on a Earth, suppose we want to do all this experiment before going to the space, we can simulate a microgravity. In the middle, you can see the equipment. Middle, you can see an equipment where we can simulate the microgravity. So one was the molecule level research, another is a plant level. The third one can be on the animals. So one of the experiment which we are going to put up to ISS is the cotton ants. You may be aware the cotton ants are native to South Gujarat, and they weave a cotton kind of things, and they are known for their social behavior. So we want to send few cotton ants in the space and see how their social behavior changes in a microgravity. I was talking to Chinmay Misan sir. He also said that he's studying on the behavior of these animals and all that. So we'd like him to also to join. So this is all from my side. Thanks. This is the controlled environment laboratories on the Earth. They are not simulating the gravity, but as I said, the atmosphere they are going to simulate. And I will just put up a video. This video is a 100 CME video which we had done.
A journey of 1,000 miles began with a single beam of light, sent not just through space, but into lives. Born from ISRO's vision to reach the unreached, a continuing medical education program took shape. The genesis of ISRO's continuing medical education, CME, emerged in 2012 during a telemedicine user meet in Ahmedabad, where doctors envisioned a future where medical learning could flow across topographies and terrains. And ISRO listened. Telemedicine is designed as a one-to-one communication platform. However, with the growing need for continuous education in the medical field, the vision expanded from patient care to physician's learning. With this vision, ISRO transformed its telemedicine network into a virtual classroom. Accordingly, Space Applications Center, being the implementing agency of ISRO, planned and executed the incorporation of CME into the already existing telemedicine networks of ISRO. A specialized software was installed to transform the network into a one-to-many communication platform, enabling the creation of a virtual classroom environment. At the telemedicine hub and across all identified nodes, the system underwent constant upgrades and fine-tunings to support seamless CME delivery. Then came a defining moment, the inaugural CME session, broadcast live on 22nd May 2013. What began as one session became a rhythm and evolved into a national learning platform, connecting minds, spreading knowledge, and elevating healthcare. From Siachen to Andamans, from Arunachal to Lakshadweep, doctors began to gather virtually, united by one mission: to learn, to serve, to heal. The implementation of CME on telemedicine network was not the work of one mind or one machine. It was a confluence of passion and precision of engineers, doctors, technicians, and researchers, video production team, and countless others from the ISRO family. SAC personnel at the heart of the operations manage studio transmissions, technical planning, and bulk broadcast with seamless precision. The production team synchronized each element from honor coordination to session delivery.
use करेंगे ना, these are all copyright things.
these all things will be.
Behind the scenes, the research personnel
नहीं ये तो
work
actually
diligently,
saving
gather feedback
saving
from the
is
primary future sessions and ensure maximum educational impact. In a world where medicine
just
meets
मैंने
technology,
click करके रखी
it has scarcely powered on ISRO's speed-based satellite network
क्या है कि
stands getting apart from the internet-based platforms,
setting
reaching from the remote and inaccessible corners of the country. Over the years, more than 20,000
Care professionals have benefited from CME. From super specialty hospitals in cities to health centers in the hinterlands, expertise flowed like light across the space. In a field as dynamic as medicine, staying updated isn't optional, it's essential. Doctors across remote and urban India now share insights, discuss new protocols, and learn from leading specialists all in real time.
Yes, nice question.
Ongoing feedback and research highlight a clear trend: a growing demand for more diverse and advanced topics in CME sessions. The road ahead? A broader scope, deeper expertise, and stronger engagement, empowering every medical professional everywhere.
ये
In this journey of 1,000 miles, we pause for a while
और
at the 100th CME
राहुल सर को बोल रहा हूँ नेक्स्ट CME के लिए आप आइए सर.
to reflect upon the 100 threads of care,
I have a lot of other interests.
one mission and countless lives. This is CME at ISRO, where space meets soul.
This is the second reading.
नहीं कुछ नहीं, क्या करना है? Questions into question.
Questions.
Any questions? So no questions. Either people understood or did nothing. Okay, thank you. Emotional. Yes.
Thank you, sir. Arvind Tyagi, sir, is the uh, head of Communication Application Division of SEC, ISRO, and he's also one of the very important pioneer and program uh, division. He's handling for SETCOM and other services, which is very much valuable for by services given by ISRO. Please.
Good afternoon, everyone. Today, I will discuss about ISRO's effort to provide health services through SATCOM network. Some parts already my group director has covered, so I will skip those slides. But I will go in the beginning how ISRO has started doing the telemedicine and other things. See, in 1963, when India tested a first rocket launch on 21st November 1963, at that time, the peoples were telling that in India, India is a very poor country. Why we are going towards space? Then Dr. Vikram Sarabhai, who is the father of ISRO, we can say, then he said that we must be second to none in the application of advanced technology to the real problems of the man and society. So in late 60s, that person was having the vision to use the space technology for the benefit of the common man and society. So as a part of space technology utilization, ISRO started many projects like in 1975 site program was done, then JDCP was done, then Kheda communication project, then we moved to the GramSat project, TDCC. So many projects have been done so that the to educate the remote peoples and also to bridge the gap between the remote peoples, those who are not getting the good telemedicine or medical facilities. See, in 1983, concept feasibility carried out by the Apple satellite. Then in September 1997, DECO initiated dialogue with Messrs. Innovative Communication System Limited, Hyderabad, and demonstration the telemedicine facility between Jabua and Delhi concept on 15th August 1998. So ISRO started taking initiative since 1997, and in 1998, DECO and Antrix, earlier it was Antrix for ISRO arm, it is commercial arm, had the interaction with various vendors like Medilink Services, Hindustan Technology, and Online Telemedicine Research Institute, that is OTRI. This company was from the Ahmedabad. It was run by Dr. Ragesh Shah. So in 1999, we constituted a task force for DECO ISRO and SAC Ahmedabad. And in 2000, GramSat PMC and PMB was constituted. And in November 2000, DECO was constituted and uh, telemedicine project was defined under the GramSat project. Here, I want to tell one thing that after that, ISRO selected OTRA, that is Online Telemedicine Research Institute, which was based in Ahmedabad, to provide the telemedicine software to have the telemedicine services. And in 2001, pilot network was tested for two networks between Apollo Hospital, Chennai, and Aragonda Hospital. And in the same year, subsequently, we established 5 nodes telemedicine network for Karnataka. After that, we reached to around 900 terminals, including telemedicine network and VRC network, that is Village Resources Centers. This node was there, which was having multiple applications like tele-education, telemedicine, even remote sensing data also for farmers. So that it was the VRC network. Under that, we were having around 490 terminals, and 399 terminals were there for telemedicine. But as in district level and block level, the connectivity was increased like 5G, 3G. Now we are getting good bandwidth. But in 2001, nothing was there. Means very low data rate connectivity, and even mobile was not there. We were using ISDN, which was providing only 128 kbps. So at that time, at the rate of 384 kbps, and we provided the telemedicine network connectivity. And that time, the antenna size was 3.8 meter, means terminal size was very big, and the cost was around 15 to 16 lakhs. And so considering that, then we thought that how to adopt this network. Then we have taken decision that we should move to the remotest high altitude region where this satellite connectivity is more required. That is why presently we are having around 200 terminals at present. Then actually our aim was that network has been upgraded time to time to provide better quality of service and low cost of the terminal. So how we can provide the better quality of service? By improving the bandwidth data rate from the remote sites, so that better HD quality video we can transmit. Other thing, by adding the number of diagnostic equipment at the patient node, so that doctor can fetch more data from the patient to the super specialty node, so that doctor can understand better way. And the low cost, how to reduce the terminal means cost of the terminal, we have to reduce the size of the terminal. And after that, suppose earlier we were purchasing the telemedicine software and LMS software also. So we have indigenously developed uh, telemedicine software, and also learning management software, and development of fully auto. After that, we want to shift into the KU band frequency band of the satellite, so that we can have the low size or very compact type of the mobile terminal, even for man packed terminal. So our ISRO aim was that time to time we have to upgrade the terminal, so that we can provide better service to the people of the India. So actually, I will tell a little bit. It is technical, but these are the basic elements of our telemedicine network. That is VSAT hub, space segment, telemedicine server, telemedicine software for telemedicine consultation, learning management server, LMS software, and super specialty node, and doctor node, and patient node. So this is our latest. After we have done so many modifications, presently download speed is 25 Mbps. Earlier it was around 7.2 Mbps. So from 7.2 Mbps to, we have increased download speed from hub to remote locations 25 Mbps, and from return link from 512 kbps or 300 kbps, we have moved from 1 Mbps or even 1.5 Mbps from the remote sites. And we have added a number of diagnostic equipment also. So we like this, we are improving the quality of service, and also to minimize the size of the terminal. These are the elements of the doctor node, that is VSAT system, TMPC with doctor and software, processing of all the diagnostic data, video conferencing, X-ray view board, and printer and UPS. We are also providing the printer. And this is upgraded patient and terminal. You see here diagnostic equipment, we are providing 12 lead ECG machine, digital camera, otoscope, dermoscope, multi-parameter monitor, digital stethoscope. Means suppose at patient node, a person is putting stethoscope, so the audio file is created, or online direct plug and play type is there. So doctor can listen its heartbeat in the speaker itself. And we are also providing the multi-parameter device, which is having 6 lead ECG machine, BP monitor, oximeter, temperature, and pulse rate, and blood sugar, and weight machine. Means this weight machine is also connected through the Bluetooth connectivity. These are the diagnostic equipment which we are providing at the remote centers. Now, as I said that we have upgraded the RF portion also. Earlier, it was the we were using DVS technology for VSAT connectivity. Now we have upgraded our VSAT or telemedicine network with DVS2 connectivity technology, and it saves the 30% bandwidth. Means once we have upgraded our terminal, that is why we have increased the data rate, because in the same bandwidth, once we are using DVB-S2 technology, then there is a 30% increment, means we can use more data, 30% more data to pump from the remote center or from the hub. And we have also replaced that transmitting power from 2 watt to 5 watt. So 2.5% power we have increased. So in the same way, data rate also is increased. It actually it has the many advantage, like we can do the HD video consultation, and interference will be less, connectivity will be better than earlier. Recently, since one or two years, we were facing the 5G interference in our satellite communication. So we find out that why this interference or intermittent connectivity is there. So to then we came to know there is a interference from the 5G base stations. So to remove that, we use the 5G rejection filter, and LNBC we have replaced with the LNBF with 5G interference. So after replacing that, our connectivity become constant, and the quality of telemedicine consultation was improved. Then in the same way, as I discussed, that telemedicine software also we have developed in-house, and we are using our in-house developed telemedicine software, and because of that, the price of the remote nodes is reduced by certain amount. See, already it has been discussed. Recently, we have developed this Antrix Adharit telemedicine software, and for that we have developed telemedicine portal. And this telemedicine portal is displayed at all the remote centers. So from the remote centers, they can access the previous data also, and even like Jitsi Meet multiple video telemedicine CME feedback, means they can give the feedback also online, or they can put their topic that we want to have this one, or they can have the telemedicine consultation schedule also they can put on this web portal. Okay, as already Sudhir sir has told that we have also implemented the multi-point video conferencing in our telemedicine network. Actually, what our plan is there, once we have provided the satellite connectivity, it can be used for other purpose also, not only for telemedicine. It can be used for tele-education, means telemedicine, tele-education, and also for the for their official purpose, we can say for e-governance. And here, one main thing, this is also recently we have interfaced this multi-parameter device, and we have written the code. And now, what facility we have created? Suppose one terminal, or suppose हमारी 50 remote centers are there. So one doctor can see all the 50 nodes at like ICU monitoring, as we are monitoring different patients. So one MPU is having around 64 patient, they can monitor from that. So in place of bed, we have allocated the number of remote centers. So suppose one super specialty doctor is there, he can select suppose one, then we have allotted one remote centers. Then if he is selecting four, then another remote centers we have allocated. So doctor can see different parameters from the remote centers, and they can monitor the patient health. Now we are going to the have the portable systems, and in house development it is there, that is this is SOTP, means SATCOM on the pose. So in that, so you are taking the vehicle to the some locations, and it is fully auto deployable, and we can connect this one, and along with the telemedicine systems will be there. This is a requirement in defense and ITBP area. See, this is also developed in the sack only. This is uh, we are telling it is a man pack, but still its weight is around 20 kg. We are in the process to reduce its weight around 10 kg, but still we are planning to use this terminal on the small vehicles like Innova or Gypsy, so that and along that we will be having the telemedicine systems. So highly mobile or highly portable systems we want to design at SAC, and we want to implement in the telemedicine network, so that in future we can give to the defense or ITBP or paramilitary forces, or we can implement these networks in remote area also, because in India still like in Uttarakhand or in even in Gujarat, so many places are better connectivity is not there, so we can have the project for these highly remote area also, so that ISRO can help to provide the telemedicine facilities at these villages or remote areas. One more thing we are doing, that as we know that suppose any drone is there, we are controlling with the remote, and it is having a limited line of sight visibility, then your remote control is working. But now we are doing that along with the drone, we are putting the SATCOM trans receiver also, so that we can give the command to drone, and when there is a out of visible area or out of the remote control area, then it will automatically take up the satellite communication, and it can go up to the 100 kilometer also, and it will be having the two-way connectivity also, so that suppose drone is taking any photograph or collecting any video, so you can have the two-way connectivity also. So this project is also under development at SAC ISRO. And actually, this is around the about Holike Sri Amarnath ji. Already, Sudhir ji has told that this year we have established 8 terminal to serve the pilgrims of the uh, uh, who is going to the visit Holike Amarnath ji. Recently, day before yesterday only, we have inaugurated this CRPF network. These are maximum nodes are implemented in Northeast region. So you see this DGP sitting in the Delhi, we are sitting in Ahmedabad, and all these remote centers are there, and it was done remotely. Actually, this is one picture when Virendra Kumar ji was our DECO director. At that time, what actually we have modified our VSAT system, so that in glacier area or in high altitude, there was a problem in the electricity and power problem was there. So we have given the solar panels also. And at that time, we were facing problem that in a high altitude region, there snow problem was there. So we have tested this terminal inside the glacier tent also, so that when there was a more snowfall something, then they can operate in from the inside glacier tent also. These are some pictures already it is shown. These are glimpses of CME program. And this is a conclusion that 30% improvement in spectral efficiency through DVS2 implementation. 4 dB link margin improvement was there from 2 watt to 5 watt. Reduction in 5G interference through filtered LNBF. Support for HD video consultation and multi-part video conferencing. Reduce TM cost by using in-house developed telemedicine and LMS software. Future plan, scaling network to support future demands, incorporate better technologies such as VIP phone for greater capacity and research. Successful implementation demonstrates the importance of keeping pace with evolving satellite communication technology to maintain service quality in the face of growing interference and bandwidth demands. So in future also, ISRO is looking to support and to provide the compact mobile telemedicine and portable systems for highly remote region, not only for defense, but we are also planning to provide, like in Gujarat also, so many areas are there, good facilities are not there, or even good network connectivity is not there, like in Uttarakhand or Northeast region, or in J&K region, and also in Andaman Nicobar region. So we are looking to expand our telemedicine network in future. Okay, thank you. Any question? ये slide है. Sorry, इसी को ऊपर दो line.
Thank you, Arvind Yagi ji, sir. Now I would welcome Shri Virendra Kumar sir to say a few words about ISRO and SEC. In this one. Just one word about Virendra Kumar sir. He was the one of the key pioneer in Chandrayaan-1 mission, and of course pioneer in telemedicine.
Thank you, Ishan. And I think it's time to wake up. Good afternoon.
Good afternoon.
Yes. So we are up now. I led this activity of telemedicine from 2015 to 2021. 6 साल तक मैं इस एक्टिविटी को लीड कर रहा था और आज प्रेजेंटेशन देखी मैंने सुधीर की और त्यागी की. सो आई एम वेरी हैप्पी कि मेरे रिटायर होने के बाद भी चीजें बड़े अच्छे से चल रही हैं आगे. सो गुड वर्क, कीप इट अप. सो कुछ एक चीजें मैं आपको बताना चाहता हूँ, जैसे कि ये विजिट की बात त्यागी जी ने बताई थी. द ऑफिसर ऑफ द आर्मी यू सी इज लेफ्टिनेंट जनरल पन्नू. ही वाज कमांडर ऑफ द 14th कोर इन सियाचिन. तो पूरे सियाचिन की लड़ाई अगर लड़नी है तो दिस ऑफिसर वाज रिस्पॉन्सिबल. ही वाज सच एन ऑफिसर. ही इज स्टिल देयर. ही इज नाउ रिटायर्ड. ऐसे ऑफिसर्स की आप शक्ल देखिए एक बारी तो आप उनकी देखते ही रह जाएंगे. ऐसे जबरदस्त ऑफिसर है हमारी आर्मी पे. सो व्हेन डिस्कशंस वर टेकिंग प्लेस कि हम टेलीमेडिसिन नेटवर्क, मैंने प्रपोज किया था इनको, आईडीएस को, इंटीग्रेटेड डिफेंस स्टाफ को, कि आप सियाचिन ग्लेशियर में आपके पोस्ट होते हैं वहां पे लगाइए. सो मैनी ऑफिसर्स आई डेल्ट विथ, वो मेरे को बताते थे देखिए आपके एंटीना होते हैं वहां पे तो -55 डिग्री टेम्परेचर हो जाता है. इतना कम टेम्परेचर होता है तो केबल्स जो है वुडन हो जाती हैं, टूट जाती हैं. यू हैव टू गिव अस वेरी स्पेशलाइज्ड इक्विपमेंट जिसमें ऑटो हीटिंग और ये सब हो ताकि एंटीना डी आइसिंग हो जाए. केबल्स जेली फील्ड होनी चाहिए ताकि खराब ना हो जाए. तो हमने उनसे कहा कि आपकी सर्विसिंग कौन करेगा, इतना कॉम्प्लेक्स सिस्टम हम दे देंगे तो ये तो चल नहीं पाएगा. देन आई आस्क्ड देम अ क्वेश्चन. मैं कहा आप लोग कैसे जिंदा रहते हो वहां पे? आप ह्यूमन बीइंग सरवाइव कर सकते हो और हमारे इक्विपमेंट सरवाइव नहीं कर सकता. सो दे टोल्ड अस नो नो, इन द ओपन एरियाज वी हैव टेंट्स लाइक दोस. दे आर अबाउट 4 inches thick and we sometimes live in that if the conditions are bad. So I told them, why don't you put our equipment within that tent? If you can survive, our equipment will also survive. It's a low cost equipment. Anything breaks down, we can go on replacing them as and when required. So for testing those, I led the team to Leh and we placed the equipment, as you can see, within the tent, and I told them to zip it up. So this 4 inches tent was completely closed and there was no difference in the level of signal which was being received or transmitted, and things were working perfectly. And at that time, General Pannu came over, landed in his helicopter, and straight away came to our tent. So he was discussing how the things are behaving, and that's his wife along with him. Now, from Leh, if you go a little further up to about 17,000 feet, there is a post whose name is also Kumar Post, same as my name, Kumar Post. So he said that we should begin from there. And he put me a question, Mr. Kumar, ये बात कैसे करते हैं फौजी? Mr. Kumar, can your boys go to Kumar Post? I said, no, normally a scientist would say, sir, we need clearances, we are not acclimatized, we'll have to, take our time. So I told him, sir, if ISRO can go to Mars, your command post is not far enough. Oh, he was so enthralled. And that's what I'm talking to him. That's what I'm saying to him right now. He never expected this kind of reply from a civilian. He said, on the spot, he took decision कि इस पोस्ट पे लगेगा, इस पोस्ट पे लगेगा, उस पे लगेगा, सारे सियाचिन को हमने फिर subsequently network कर दिया. हमें जाना नहीं पड़ा. He was only testing us. So what we did was we trained their people so that they can carry the equipment and install it and use it themselves. And this program became one of the most successful stories in telemedicine. You see, Siachen Glacier का आप imagine कीजिए 17,000-18,000 फुट पे हमारे जवान बैठे हुए. If one person develops, say, stomach ache, and the report comes, he's not well. Now the doctors who are down below, उनको नहीं मालूम what is the seriousness of the situation. So they are pressed on to launch a sortie. Helicopter भेजो ही भेजो. And now suppose the weather is not good, but they are not sure what the condition is. So anyway, they have to launch, and many times we lose people in accidents. But after installation, the things have become very far better because now doctors can ascertain whether it is really necessary to launch a sortie of a helicopter right now or can we wait. So that judgment can be made. And further, if the person actually needs to be evacuated or he can be treated there itself. So with that judgment, the number of sorties of helicopters had come down to about 25% of what there was for evacuation of Jawans. So that is a big save. Plus the number of accidents have come down because now they can launch when the weather is better, and when the weather is bad, patient can be handled from down below. One more instance I can tell you. One of the army doctors in a high post, the weather was bad. He was playing cards with his buddy. He just collapsed. Doctor himself at such high altitude. Now, weather was bad. He could not be handled, evacuated immediately. So he was maintained overnight through telemedicine from Delhi, RR hospital. Then, when the weather was little better, he was brought down to a lower post. And then one doctor went on helicopter to the other post. And there also he was maintained through telemedicine by that doctor in direct consultation with the RR hospital in Delhi. Then when the weather became little better, he was evacuated to Chandigarh airfield. And the same doctor accompanied him on board the aircraft. On the aircraft, that poor doctor suffered a heart attack. He was revived by that doctor on board the aircraft. And he was transported to Delhi while still alive. I think these things would not have been possible if telemedicine was not there. There have been stories of colonels suffering gunshot wounds and being maintained through telemedicine. So telemedicine, as we say, does save lives. And I think we should keep on pushing in telemedicine and go further and further in this because this is the future. The oil shock is coming. I don't know what will happen to the world. I mean, the kind of connectivity we see, the connectivity through fiber is easiest one to get disturbed. The mobile phones can get disturbed once few bombs are dropped. So SATCOM continues to be important because on a rainy day, this is the service which will keep us connected. सो इसको भूलना नहीं चाहिए, इसके साथ साथ चलना चाहिए। बाकी कनेक्टिविटीज भी एक्सप्लॉइट कीजिए, पर ये करते रहिए, इसको भूल मत जाइए, बिकॉज रेनी डे में यही काम आएगा। थैंक यू। कोई सवाल तो बताइए।
नहीं सर, सवाल नहीं है। थैंक यू वेरी मच सर। हमारे ये कहना है कि मुझे लगता है यहाँ हम सब लोग हैं, आप ह्यूमन के हैं, और थैंक यू टेलीमेडिसिन के हम इसरो के साथ इतना कनेक्ट हो पाए और हमको इतना पता चला। सो माय हम्बल रिक्वेस्ट टू यू एंड योर होल टीम that please sir put all this on paper or rather write a blog or anything. So whatever is there, should have learned. We can learn from reading it. We can uh, learn from seeing it. Thank you, sir.
Now that I am retired, I have a YouTube channel of my own. I make videos and put online. So maybe I'll make some videos capturing these instances also. Thank you.
Thank you, sir. Now we move to our next lecture. The lecture is about mobile application in healthcare. To present the lecture, I would like to invite Shri Taral Shah, sir. And Taral Shah, sir, is very deeply involved in strengthening the technology ecosystem in Gujarat. And he will put his valuable insight on this mobile application in healthcare. And to chair the session, I would like to invite Dr. Chinmay Shah, sir. Dr. Chinmay Shah, sir, is Dean and Head of the Department of Physiology in Bhavnagar Medical College. So, thank you.
So thanks, Tarun, for accepting our invitation. He's a big diplomats, having a more work internationally, and we are very much to have in this session. Thanks.
Thank you, Rajbhai, for inviting me to this August audience. And good afternoon, all. I'm Tarun Shah. I'm co-founder of Techify Solutions. Apart from being a technocrat, I'm also being active in the Tech Expo Gujarat, which I'm leading, which is one of the IT initiative of Gujarat to bring the IT community to the world landscape. I'm also part of the GCCI's architect, AWS architect, but that's not the enough to be present here, just to be with you, because it's a medical fraternity, is not from the medical background or connected with the healthcare. Yeah, so my little added advantage over here is I am from a medical family also. My father was a doctor. My wife is a dietitian. My whole best buddies are the doctors. So that has given me little added advantage that I can come and present something healthcare to you. Now, my today's topic is about the mobile apps and how the mobile is going to drive the healthcare, the next wave of the evolution. And not only mobile, the AI would also be one of the pioneer for that. So before I begin, I would like to know from you, how many of you are using smartphone over here? I'm sure everyone, right? How many of you are using more than 2 hours in a day the smartphone? Around 50%? And out of that, how many are using more than 1 hour for your work, the mobile phone? Very few over here, right? So what we are not saying is the one of the cheapest medical device is in your pocket. Starts from around 15,000 rupees. It can go to 115,000, but start from 15,000 rupees. You have a medical device in your hand. And how can you use that? Oh, that's wonderful. Okay. Sorry, I have to be here. I'm normally used to walking around, so it's a little odd for me. And if my voice is audible, I'm more comfortable on this. Is my voice audible over there at the back? Oh, perfect. Great. Thank you. So we all know the most powerful health is in your pocket. And we all know it's more reliable than some of the government hospitals you are working with, right? It can give you the best of the data, it can give you the best of the knowledge, best of the information. What you need is available at your fingertips. And how healthcare can benefit from that? So let's understand few challenges which healthcare are having right now. One of the biggest is the limited access, the doctor-patient ratio. By 2027, believe. અવાજ નથી આવતો.
ઓનલાઈન પાર્ટિસિપન્ટ્સ પણ છે.
Oh, અચ્છા.
રેકોર્ડ પણ થઈ રહ્યું છે.
Okay.
તો
Sorry, yaar. So it's said that by 2027, 75% of India's population would have a smartphone. But at the same time, we would have a doctor to patient ratio of 1 to thousands. There would be like a 600 Indians, they would be living beyond 5 kilometers of any qualified doctor. That's not a gap. You can say it's a canyon, and the mobile would be breached for that. Your delayed diagnosis, we know those critical diseases like strokes, MI, they all cost the lives. And you need continuous monitoring also. One thing which India should never be proud of, which is number one, is the diabetes capital. It's the diabetes capital of the world right now with the highest number of diabetic patients over here. But with the continuous monitoring, with those mobile devices, wearable devices, you can overcome that. And that's what the thing is. This small, powerful device in your pocket would be changing the life for lots of people in coming years. How the healthcare has evolved over the years. So starting early 90s to 2000, 2015, it was majorly hospital-centric care. And I would say that let us go back to 2015 with the special mention from the ISRO, which they already started the telemedicine, right? So those telemedicine era started, the video consultations, the remote monitoring, everything has started. From the COVID time, it is becoming more and more mobile-first approach. I'm sure quite a few of you might have already contacted your doctor over the mobile, right? And still, and for that's a problem for a lot of doctors also, because now what has become a problem for doctors is they get all the reports on mobile. The patients also prefer to talk to them on mobile. They always send a message and say that, oh, please reply me that. The wave is changing. It would going to be AI-driven healthcare, in which I'm going to talk about that in coming slides. Most important for all of us to understand is from patient going to the hospital, the wave has changed, hospital coming to the patient, and now it would be hospital staying with you. That is going to be changed with the mobile devices. So be ready for that. That change is coming up. Now with the mobile device, you have everything on the hospitals available with a just click of the buttons. Now, how this mobile apps play a key role here? The first thing is the access. With telecommunication, we know that it connects the doctors with the patients, and everybody over here is, we are here for that purpose only, right? The Telemedicine Society of India, we are here that the teleconsultation is the being the norm over here. And it's not a new word now. It's been coined years back, and then it's being in the practice now. And we have seen from Sanjay Bhai also that now it's the operations and the surgery is becoming normal with the telemedicine. So things are changing drastically. One thing which is becoming more and more is the wearable devices. With the Apple Watch, Fitbits, a lot of things, the wearable devices are coming more and more picture on that. And from there, the intervention would come in a picture. So I'd share one anecdote here. We work on a project for a US-based cardiologist. He was a very renowned cardiologist over there, and he was also a scientist. He came out with an algorithm that if a patient is having a pacemaker in his heart, that pacing rate is normally fixed over the period of time, and then doctors are not changing the pacing rate. He came out with an algorithm that if based on patient's condition like his BP, weight, some of the other conditions, the ego, his pacing rate should be changed. And if it's changed, it brings a longevity to the patient's life. So we already did one clinical trial over here in India for the 50 plus patients. The next wave of the clinical trial is going to begin soon on that. What is that going to impact? If that's working perfectly fine, those algorithms would now be coming to your wearable devices. Now, those wearable devices can easily monitor your BP, diabetes, the pulse rates, everything. And if it finds something alarming, or finds something to be changed, you just take your wearable device near to your heart. Using the Bluetooth, it can easily change your pacing rate. So those mobile apps are going to be playing a key role over there. Think about interventions, those real-time analysis, real-time diagnosis. These are going to come over there. They would have the data. Now the data's next way would be how do you run those analytics and get the data making it more and more meaningful for you. That's how it would come for you. So I'm not going to talk about the mobile apps to use.
because if you just go to Play Store, App Store, you would find millions of apps for that. And based on your purpose, based on usage, you can use any of the apps. I'm just listing a few and very minimal use case here, which you are seeing right now. One we all know, it's a telemedicine. We all know the next wave, and Dr. Rajbhai can vouch for that, right? He did something during the Corona time also. That's one of his dream thing also. The tele ICU monitoring, that's coming in that now for the remote places, for the critical care patients. How to get the ICU facility? They might be able to get the ICU facility, but they would not get the experts. But with tele-ICU, this can become a possibility now. So that's the next thing. Diabetes and BP tracking. I'll share one example again on that. I have one friend who is my client also. He's a US based. He's a good Jew, but he's also foodie like me. And whenever he's coming here to meet my team, but his major focus is, let's identify at least 10 restaurants we should be going over those 10 days. He is a diabetic and he wears that wearable device. He has that machines, everything on that. One day we went to a South Indian restaurant. He just had ordered a rava dosa. Post rava dosa, he figured out that his diabetes shoot up by around 50 points, which has never happened to him before. And he was really surprised why that happened. Maybe something was not good with the rava dosa, or maybe that flour was not good, something. But he got alarmed that, okay, whenever I had that rava dosa from that restaurant, it alarmed him saying that, oh, boss, something is wrong with you. Be careful. So now when you are going to have the next diet, please take care of that. That's the diabetes and BP caring. It's very important for all of us. Now, lots of apps are also available, right? That's we are also talking during the break that mental health would be the next thing. People, because of this mobile wave and the different kind of a mobile apps, social apps, everything, the people are also getting the mental problems also. And there are lots of apps also available which can find out that if you are having any mental challenges, mental problems, how to rectify on that. You would be surprised. I found almost 1,000 plus apps just to help you go to sleep. So they would be making different sounds over there, which would keep continuously running to make you feel better sleep on that. So you can understand how this mental health and then issue would be helpful to you on that. And then emergency response, right? So we all know that there are the emergency things. We have the ambulance available, your tracker, even each of our mobile device has that SOS number, right? You press this button, it can call the emergency numbers. So these are the very practical use cases. And that's where the mobile is being indispensable for all of us in our life. Now, how would this come in a picture is mobile is going to be fulcrum of everything. When you talk about, you would have a healthcare providers who are going to talk to the patients. So there would be patients, there would be healthcare providers, they would be using the telemedicine apps, tele-ICU apps, or anything on that. Mobile is the fulcrum. Now, what the data is being generated, that will be stored on the certain cloud infrastructures. But that cloud infrastructure does not just store the data, it would running the different analytics. It would run the analytics, it would give the predictive analysis. Also, apart from that, you would have a connected devices. Again, I'm coming back to wearable device. This would be a very important thing in the coming years. With the AI wave, this would be a very important, those wearable device is going to change the life for not many people over there. And that data is coming over there again in the cloud. Those analytics will help you to predict something is wrong going to happen to you, would help you to improve the things. So those are the things coming up. The mobile apps would be playing again a central role for all kind of a thing, whether it's a telemedicine, tele-ICU, any future diagnostic of the systems. That's the important thing for all of you. Now, when we talk about that, some of you are here are the students, some of them are entrepreneurs, some of them from the health, fraternity, the scientists, everybody's here. What I see is there are 4 massive opportunities for everyone. And we have to grab that opportunity. First one is there are 640 million people who would be in the tier 2 and 3 cities. I consider Ahmedabad to be the tier 1 city. So considering that, there would be people who would be in the tier 2 and tier 3 cities. They would not have the specialist doctors available. Some of them would be having a 50 kilometers away. And I'm sure the doctors over here would vouch for that they are having a patient from the remote places for the special advice. This is very important. Mobile and telemedicine would give them the instant access to the doctors, instant access to the specialist, and they need that. Remember, the next generation is a beta generation, alpha generation, Gen Z generations.
and they need that kind of a thing. I always keep on telling that's a real generation. It's an Instagram reel, right? So this is the real generation. They need the quick things. They need the things to be delivered them quickly way. And the things are changing for the medicine industry also on that. On top of that, we have ABA, right? The government has started ABA. That's an amazing thing. We have a lot of people have talked about the ABA also today. It has already given them a health identity. And now ABA on a longitude way, if you think about over the period of time, the ABA would be carrying a lot of records for you. So if you have linked your data with the ABA over a few years, your records would have a lot of information about you, your early diagnosis, early diseases, everything would be traveling with you. No matter where you go, it would be there. Second would be the startup innovation. We are already in the TSI. Vishwajit Bhai is not here, but he would be. They are also going to talk about some of the startups. There are startups coming up in the healthcare industry. A lot of startups are doing that. But the biggest thing is everybody needs to know there would be always first mover advantage. Early you move, early you adapt, you would be the leading that field. So be ready for that wave. At the same time, our government is also pushing a lot for the digital transformation of the health. There is a 7,500 crore plus, and this is just the number. I'm sure there would be much more than that. Is coming. There is an e-Sanjeevani app. There is the DPDP app coming. Everything is coming up. Be ready to grab that thing. The most important is this should help the affordable care delivery. Now, it would help you. The telemedicine slashes the consultation cost. And it's very important for everybody to note with mobile apps, or other AI, I would say, they are not going to take away your job. Rather, an app which is available at free of cost may take away a consultation which the doctor charges 500 or 1,000 rupees. Because in the next wave, people would prefer going to those mobile devices, mobile apps, get the early consulting from there because of the convenience instead of going to a doctor over there. So everybody has to start adopting those things earlier. Be ready for that next wave. And why I'm saying this is my father used to be a doctor, and I have seen there was always a loyal patients to them. And patients, even if they go travel somewhere else, they always miss my father and they say, "Oh, we need to come back because your medicine works as a charm for us. They are like a magic for us." But what about if these patients have moved out of the cities? They would never be able to connect with my father. And then doctor, it used to be not just a doctor, a consultant for them, right? It was like a family member who used to listen to their concerns also, guide them also, mentor them also. They used to do everything. And now in that scenario, when you think about if doctor is talking to them over phone or over telemedicine, that would help them immensely because they are in a new city. They might not have their family around them, but just a call to the doctor, consulting with their familiar doctor would solve a lot of problem for them. So for them, it's a very important for to know that this change is coming. You all need to adopt because as a doctor, if you think about that, oh, I cannot do the telemedicine, I cannot adopt the technology, then be ready because there would be a people who are ready to change and adopt the technology much faster way. At the same time, for the entrepreneurs and anybody making their apps or anything, or the doctors, we had a very good sessions in the morning about the data privacy, data security. These are the challenges we all need to know. Data privacy, data security, we had a good session about that, so I'm not going to talk about that. Same way we had about the regulatory compliance. One more important thing is for doctors need to adopt the technology. Still today, and I was just talking to Sanjeev Bhai and a lot of people also, right? Doctors are writing everything on a manually, on a paper. And sometimes even their handwritings can be decoded only by the chemist. Right? It's not easy for everybody to understand their letters also. Now, you need to adapt the technology. You need to adapt the computer, mobile. Now, there's so many easy ways available. It can easily translate your speech to text. You just speak out, it would write down everything. It can convert everything to your digital data records, your telemedicine compliance. Everything can be done here. You need to embrace the technology. If you don't, there would be somebody else ready to adapt that. And whenever you are making that, the most important thing would be the user experience. Think of any application you are creating should be a user friendly. Think like it's a WhatsApp. Your grandmother can use a WhatsApp. She can send a message at 6 a.m. in the morning. Will she be able to use your application and book a doctor appointment? Will she be able to talk to doctor easily on your app. If that's possible, then you crack the logic. That's very important, that user experience is the thing for anybody working on their apps for the part of that. The future of the health is now going to be AI powered. And we have seen that AI wave is coming up. And we would have also session on the AI upcoming on that. I may take a little bit about the AI in this. But we know that now machines have started learning. They've started detecting the patterns. Those ECGs, X-rays, everything is now started being imagined, and then AI recommends that. If you have your own, any of your medical report, right? I met from the Sterling Diagnostic, is here over there. And I used to tell them that whenever I get the report on PDF on my WhatsApp, I can give that report ChatGPT. It would analyze each and everything for me. I don't need to go to a doctor. It would tell me what is within, though they tell, but what is within limit. What are the things I need to take care of that? What are the things I should not do about that? Yeah, they always put a last line saying, always talk to your doctor, have a consultations, then only follow this. But everything is available to you just based on report. You upload any of your medical report and see the magic being happening to you. This is happening, right? So predictive healthcare, the continuous monitoring, we talk about that, and that's going to happen. And that's where the AI wave is going to come. So what I see is how AI is making the mobile health dramatically more powerful. How many of you know AI apart from ChatGPT? How many of you have used AI apart from ChatGPT? So a few of them. Apart from ChatGPT and Claude, have you used any other AI? Few of them, right? We don't know what AI can do. There are thousands and thousands of tools coming up, thousands and thousands of apps coming up. I just give one example, is a Fundus. I got the reference. So it's not something I know very clearly, but that's an African-based app which helps them the diabetic care, right? It's an AI-based. I'll come to some of the names in the past, next slides also, which are the Indian ways which helps you in the early detection of the things. There are so many AI apps are coming. The AI wave currently is more like a co-pilot. Co-pilot is more like it's a helping you. It's an aid to you, where it would be like when you are flying a plane, there would always be a co-pilot with you, which can guide you for certain things when you need that. Exact that thing AI is doing right now. So what you can do is like a multilingual support. You would have a patient from the Telangana, Tamil Nadu, anywhere. They would be speaking in Tamil. You don't understand, just start the GPT. Let it speak. It would dial. It would interpret everything for you, give you everything in return on that. For so many times, it has happened to me also. Like I would speak everything in Gujarati and ask that, okay, please convert everything to English for me. It would write down everything in converted language for me. So that's a one very basic use case, very minimal use case. AI is so powerful than that. But for doctors and everybody, this is very powerful case. Voice to AMR. For you, when you are writing things, you do, and we know people don't love to write a lot. People don't love to type a lot also, right? Now everywhere, the speak and then speech to text has come into the picture. You just speak, and then everything will be converted to text. It would also help you. There would be agents and everything which can help you to convert those records to EMR. If you have the right systems available, right agents available, they can connect to the ABA, push down the records over there. Everything is possible over there. The real-time diagnosis, I just talk about you upload your report to GPT, upload anything, and you get all the data from that. And they would analyze for you. They work on that. And believe me, this is just a beginning. I'm sure those all AI providers have started talking to FDI and everywhere. They are under the approvals to get the approval from the government that we can recommend something to you, right? So in the next phase, you should, in the 26 to 28, AI will be coming more and more as an orchestrator, where it was your co-pilot. From that, it's going to the orchestrator part, where it would give you personalized health recommendations. Like I just talk about a case, right? Somebody's diabetes just shoot up. It can immediately note and guide you that something has happened to you, you should take care of that. There is a predictive alerts before symptoms worsens, right? So you are having a continuous monitoring data going on. The data is being captured in the cloud to the AI. It would analyze the data and signals you that something is wrong on that. With ABHA, your history is being created. And believe me, over this period of time, India has a huge number of data available. And if that data is being used correctly, with a lot of doctors would have a lot of data available. If that data is being used correctly under DPDP Act and everything, it would empower to get a lot of analysis, lot of predictive learnings, and the recommendations for them also. Your routine clinic tasks would be automated. So patients coming to you, they would be like, need your appointment, they need to do a follow-up, medication alerts, everything would be automated. There would be agents running for you. I give you an example, and because what we are seeing in our IT industry, it's being taken over by the AI drastically. And that's a big push for us also on that. And then same thing would be happening for you from 26 to 28. Be ready for that. I'll give one example. I met one guy who is an IT CEO. He's based out at Surat. He used to have 100 people company at some point of time. He says, now I have only 2 employees and 146 agents who are running my company. Those all agents are the virtual AI agents. No human over there. Whether it's his HR task, it's a admin task, their payroll task. He has created all the agents and they are doing his job. Even for my organization, I talk about that we are doing a lot of mundane tasks when you talk about the day-to-day tasks which you are doing. Everything is now automated by the AI. So think about that. That's going to be coming for you. 28 onwards, we don't know. But that's all the robots and everything AI would be coming as a care agent to you. You would have a autonomous chronic disease monitoring, the chat assistants, federated learning, the real-time epidemic clusters, AI first rural primary care, everything would be coming to you. Think about when the mobile phone came into the market in early smartphones, I would say 2006, Apple launched that. From there, the app started, the internet started. It took them the 10 years, 15 years, 20 years kind of time to what it is to now. AI was first launched much more like in 23rd end or the 24th mid of the year. And what it is now is a very different level. It's catching up so fast. So one of the recent study about the GPT 5.2, what they studied, they started doing the radiology analysis, the predictive for the X-rays, ECGs, and everything. And what they observed is like 5.2 was much more accurate than a junior doctor, a junior radiologist could do that. So you upload any X-ray, ECG report over there, the GPT 5.2 can give much better predictions and the results compared to a junior doctor. Yes, it claims that we have not reached to the senior doctor level, but the way they are catching up, I'm sure it's not away years, it's just months away where they would be able to reach to that level. So things are happening and be ready for that change. Now, how you can leverage AI, right? So we are all using mobile apps and this is all part of that. So you can always use for the faster diagnosis, automated follow-ups. Somebody's phone is coming, sorry. It's okay. So for automated follow-ups, the medical documentations, the predictive insights, the remote monitoring, everywhere you can use that. And a few of these things I'm just noting down here. Yeah. A few AI tools I just want to refer to you, right? And which you can use in day-to-day life. GPT, we all know. Chat GPT is there, Claude is there. There are so many other tools are there, right? Google Gemini is there. You want to make this, give it to text to speech. You want to convert anything of that. It would be very, very helpful and powerful to you. There is Ada Health and Babylon. They are the AI-powered symptom checkers. And don't see, I've given sample names. There would be thousands of apps like that. So don't quote me that these are the only apps. I just given that for the sample and reference to you. Cure and the Niramai. I talk about that. They are the Bengaluru-based AI radiology platform that can interpret the X-ray, CT scans, and mammograms with the accuracy matching the expert radiologists. This is an India-based healthcare tech companies and leveraging AI to revolutionize the medical field of that. One thing which is very important and good to know is the Google and Azure. Azure is from Microsoft. Google, we all know. They started enterprise-grade clinical decision support system. That's the Google Med Palm and then Azure Health AI. What that helps you is it's about the any literature and patient data for evidence-based recommendations. It's specially designed to provide high-quality clinical-grade answers to the medical questions, and it would help you assist in summarizing medical documentation and the clinical decision makings. So when you talk about those clinical, these things are available now. So, and you'll be surprised, I've been a few of my friends, like they were working on some of the presentations, they were working on some of the case studies, and I showed them the power of ChatGPT, I showed them the power of the Claude, Like you give them the exact case that, okay, this is the case. I want to prepare the case study. You would be surprised. It would prepare a whole case study for you without even you are seeing a doctor or you are seeing a patient. It can now do for you. You don't need to go and see the patient. I know it's not the ethical, it's not the right, but it can do because it has the data available and it would not give you the fake data, right? We know that AI would have its own hallucination. We know that it would not give you the exact answers always. It would have that because they are also maturing. They are not the mature level. It would hallucinate sometimes, but thankfully they would not diagnose your mosquito bites to a cancer. At least they are much better accurate than that. So things are moving and they would be much better rate than we can because we humans can learn, adopt at certain rate. They are much faster than us. And that's what we need to understand and be ready for that. So where you can see that the AI would fit in a daily workflows, definitely for OPD settings, your case summaries. A lot of doctors over here would have all the records in a prescription way, in a file, something like that. I recommend scan it, just take a photo of that, give it to GPT. It would convert everything to a Word document for you. You can do everything digitization for you. And you don't stop there. You give hundreds of documents together, it can convert for you. And I'll give you a case where we are working with one of the doctors is there are a huge number of such a case studies. There's a lot of documents and everything available. We just give you, they were almost 15,000 plus case, something like that. We gave everything to GPT and there were few more tools used on the cloud, everything we used. We digitize everything. Now what has come out to that? Now we just go and type, oh, this is kind of a patient. Can you give me a reference? Can you give me? It would find from my 15,000 records, give me that exact file which I'm looking for to that. So you think of that, I need time to go to those 15,000 records, read that, understand that, and find it. It just now for a millisecond of time for them. What it did is it just digitized the data. So your ICU monitoring, we talk about that. The patient follow-up, right? The diagnostic, the administrations, these are the things which are going to come up for you. And you have to start adopting with more and more cases on that. Just one case study I wanted to show. I know, I'm sure everybody knows about this case study, the telemedicine ICU. During the COVID time, the Rajbir and team worked on that. It was a remote ICU monitoring that worked across the hospitals, had amazing results on that. I would like to go to one more use case on that. And I'm talking about the 2014, yeah, I think 13 or 14. I was working with Tata Consultancy Services that time. I was part of the research group. And we were working with the Singapore government. And the major case study was Singapore government used to provide a special care to their senior citizens. And they are given a caretaker to them. They wanted to take care of that because so many times the senior citizen is living alone. They don't have family. They want to ensure they have the better life, they have the better medical care, everything on that. What we did with tie up with the Singapore University over there, we installed a few sensors in the senior citizen's house. There were sensors at his door. There were sensors at his bathroom door. There were sensors at his refrigerator. There were sensors near his cooking stove, near his bed. What they were sensors doing? They were just checking their movement, whether patient is moving or not, whether patient is going for a bathroom or not, whether patient is going out or not. Simple data. It was just checking the movement. And when it finds that there is a no movement or there is a change in the movement pattern or there is a reduced movement, it would immediately alert the caregiver on the mobile saying there is something wrong. Please go and talk to this patient over there or the senior citizen. So simple use case. And I'm talking 2014 where we were working on this use case. You can think now how the world has moved from that level to today. It has changed everything. The technology is going to be the thing. We all need to embrace the technology. We all need to make it powerful. Just one slide before I conclude my session on that. With this AI, so as I say, don't take AI as a competitor. Don't feel that, oh, AI cannot reduce a medical practitioner. Eventually, some app, something can be always replaceable on that, right? So with AI, you would always have a 40% faster clinical decisions. It would reduction in time from symptom detection to treatment initiation. It would also have 25% emergency reductions. So you see something is going wrong, immediately it can alert on that. I just shared the case of the Singapore University, right? It can, and I'm talking this in 2014. We are in 2026 right now. It would have a 15% improved outcome. So the longevity of the life or the patient's care, everything is going to improve with that. And then the most important, the doctor utilization is going to improve. This is a real generation. They all need everything available on their fingertip. They need everything easy to access. They need convenience. And for them, healthcare is also part of that. They need, and then one doctor cannot be at the 100 places. The doctor has to breach this boundary from just being specific to a region. Instead to be a global player, he has to adopt this telemedicine and mobile apps where he can reach to anyone and everyone using that mobile app over there. So with that, I would like to conclude my session. Just a last note. We all know that healthcare is no longer a place. It's a continuous service. And then mobile apps are the infrastructure that provides this continuous service. Thank you all. Thanks again for hearing me.
Thank you very much, Mr. Dharam, for an excellent speech. Only two things I would like to say. That definitely AI is there, it is going to be there, we have to use it. But the thing is, Indian doctors has to come up and have to customize it. You say that you upload your reports and ChatGPT will analyze it. But still, we need to take care, we have to be alert. Because the thing is, whatever ChatGPT has been fed by is bias. And as you said, that there is a AI hallucinations, and sometimes they may misdiagnose, and I think it can misdiagnose up to a mild to a cancer lesion. So we all have to come up with the proper feeding to the AI data, and we have to have our own sophisticated customized AI tool, not the general tool, because they are always biased. Thank you very much.
No, and I'd just like to add on that. What you said is completely correct. But that's why we say in 26, it's like a co-pilot, right? It's helping you. But the way it's maturing, by 26 to 28, it would be much, much better on that. So you have to start adopting the things. You have to start be ready for that. That next change of wave is coming up. And we all have to be ready, adopt that. Then only we can go to the next level. So don't take it as a competitor. Take your as an assistant and make it a part of your day-to-day life. Then you can achieve much better. You can have a much better coverage. You can have a much better savings for you also. That's the main point.
શ્રીમતી હું કહેતો હોઉં છું કે AI છે ને એ excellent ડકોર servant છે. એને excellent કામ આવડે છે, પણ જો તમે proper guide કરો તો. Thank you.
Thank you.
Thank you, Taran sir. Just I would like to say one more thing about this last session, which Taran sir actually mentioned. Everybody knows about one simple medicine known as azithromycin. Probably many of who are sitting here, they are aware about azithromycin medicine, which is commonly used for upper respiratory infection. I have started actually telling my patients that whenever the azithromycin is being prescribed, I request you to monitor the heart rate. That is a very surprising because azithromycin usually rises the heart rate in very few patients. Say it is a very rare side effect, but it is being monitored with Apple Watch or Samsung Watch in our wrist. And in some cases where the patients are actually asking me from where after taking azithromycin or after common cold, when I can start physical activity, I seriously advise them that you just start physical activity after 7 days. So with this cardiac monitoring post even simple antibiotic therapy, if we are integrating this telemedicine devices, then it is definitely help. Now, I would like to acknowledge and I would like to welcome Mr. Mansingh Rajora sir, who is a Vice President of GSEC, Gujarat University campus, and he's also a very good help in making this seminar very successful. We are very much thankful to you, sir, and a warm welcome to you. Now, moving on the next session, I would like to welcome Shri Kunal Prajapati, sir, who is the founder and CEO of Brainiac Healthcare, and which is a medical technology company based in Ahmedabad. And he will give his insight from for the this healthcare system or telemedicine care system, where his application and other things which are in process or which in the development. Please welcome, sir. And to chair the session, I would like to welcome Shri Kunal Patel, sir. Please, sir. Kunal Patel, sir, is a seasoned seasoned product and growth strategist with over almost 15 years of experience. And along with that, I would like to welcome Dr. Leena Mende. She is a medical officer at ISRO. Always. Yeah. Thank you so much.
Hello. Am I audible?
Yes. Change कराना है और फिर एक bench जो मौजूद है. up.
I am not an anesthetist, but in the last 5 years, I have met so many, and I have learned one thing. They don't like surprises in critical cases. So, one such case I would like to share over here is I would like to share my journey from just having a thought of building something to that thing which has reached around 300 doctors across India and Philippines and Bangladesh, and it is creating such a huge impact that it has currently achieved 25,000 uh, patients. Not changing. I believe in one thing. If you don't understand the pain, you can't build the solution. That is something I have learned in the last 5 years, and that has created my journey. In 2021, while working on COVID ventilator, I come to know about a problem which is a healthcare is facing right now, and that problem is capnography. 2 out of 3 medical setups in India don't have capnography devices. So first, let me explain you what is capnography device. So it is a respiratory CO2 monitoring device that monitors carbon dioxide CO2 levels in our breathing, in patient's breathing. So that monitors it in real time. So while identifying that problem, I came to know that this is a huge problem because it helps in airway assessment, anesthesia dose management, ventilator settings, and many more things. So that's how I started my journey with just a laptop and just a thought and a huge courage to just start building. Me and my friend Sunny Patel, we have made around 5 to 6 prototypes on this device, and it was continuously failing and failing. After a few times, we started seeing some results. And then that's how we launched Respicos in July 2024. It's a portable, standalone, mobile app operated device that any anesthetist or critical care specialist or small hospital setups can carry with themselves and just attach with the patient and start monitor the patients. It is helping them in airway assessment, anesthesia dose management. Initially, in early days when we launched the product, it was very difficult. The adoption was very less. People doubted us, and that's fair thing. I believe, because that has built that thing has taught us so many things. That has built a confidence in us, and after 6 months of launching, that things took time and started growing. And this is the first few installations that we have made. Currently, Respicos, we have sold around 300 plus units across India, Philippines, and Bangladesh. 7,000 plus patients monitored, and it's available in 3 plus countries. This is one of the photo that an anesthetist sent us a few months back, and it is very close to my heart because it has changed my journey. He's he sent me a line. We can say it's a testimonial. We didn't ask; it was an honest opinion, and he told me that it's a remarkable innovation for anesthesia and ICU monitoring. And for that moment, I started feeling like, yes, I have made something really exciting. Before that, it was just a setback and learning phase, and that's how things started changing. If you know Dr. Bhavani Shankar Kodali, anyone knows? He's a famous capnography guy. He has his own domain, capnography.com. He is an obstetric anesthetist at University of Maryland, USA. I have been reading his blogs while building the device. That's available on capnography.com. And from that, by reading this, just from those blogs, I have built this device. And last year, in October 2025, I dropped a message to him, sir, I would like to meet you and show you what we have built. And that's how, and he told me that next week I'm coming to Mumbai at ISACON, anesthesia conference, and I would like to meet you. So he's just said, yes, you can come to ISACON and show me the device. And that's the while showing this device, that's what he said. This is impressive. You have built a really nice product, better than MNC companies. That thing changes. We are always grateful to the people who have, of course, we can't build this thing without any help. And to achieve this success, there are some doctors who have really helped us from our day one. Some of them are Dr. Morik Sheth, Dr. Pragnesh Vacharajani sir, Dr. Raj sir, and Dr. Bhadresh Shah. And this is our journey till now. And I'm presenting you this recipe goes to you. So it was just a, I would say, it's a setback story that comes to a success, but I don't consider this as a success. We have a long-term vision, and I would like to make this brand, Respicos, to accessible globally. And for that, in future, we are planning to collaborate with different companies and different telemonitoring. We would like to integrate Respicos with that, so that every ICU in India don't uh, so every doctor don't feel like that they don't have proper equipment to compromise with the patient's health. And he's using open circuit ventilator, then there is another problem because inspiration, they are having some kind of impulses in capnography. So it's for different application, there are different problems.
Whether there is any limitation over the arterial blood gas analysis, this limitation?
On arterial side, ma'am, there are actually both things are viable, I believe. The difference is on the arterial gas sample side, we need to take a blood sample and it gives us a result after few hours. We can say 1 or 2 hours. While Respicos or we can say capnography devices shows us real-time CO2 gas concentration. And both has I read some research papers and there is a difference between PaCO2 and EtCO2. That's a 5 mmHg accuracy. 5 mmHg difference. So that is the difference that we get.
All right. So as you were discussing, is that you were trying to also implementing some AI effects on research.
Yes.
So the perhaps give insights into the helpful that what are your plans on the same and how it's going to be integrated with the device manufacturer also.
Okay. So currently we are working on the AI segment. The device will automatically read the data, specifically capnographs. It will diagnose apnea detection, curare cleft, hypoventilation, hyperventilation, hypocardia, and so those kind of factors that we are going to identify. Currently, we have built a model on AI, and it is giving us an accuracy of 77%. But still, it's not medically proven. It should be around 98 point or 99 or 98%. So we are currently improving that. After a few months, we are planning to launch it. And we are currently also looking for the companies as an OEM. Uh, as an OEM, we would like to provide them a solution and along with AI, so that they can integrate our system with the system and they can get the better outcome on the patient side. Yeah. Thank you so much. Thank you so much, everyone.
Thank you. Thank you, Pranalji. Now, let's move to the next lecture. GUSEC, a world of startups. For that, I would like to invite Shri Vishwajit Adhikari ji. He is the Senior Vice President of AIC GUSEC, and he will be giving a glimpse on startup structure and what are the things, how they are becoming uh, helpful for the new upcomers, startups, entrepreneurs like us. And to and I would like to invite yes yes sorry I would like to invite to chair the session Mr. Mansik Rajora sir, who is a senior vice president for GUSEC. Please sir.
Good afternoon, everyone. I know the last session of the day. First, I would like to congratulate TSI Gujarat chapter for organizing TSI GUJCON today, and my best wishes and thank you for partnering with us. And yes, so as you know, Gujarat University is the oldest and largest university of state of Gujarat. So we are very much aware of how much it has contributed to the field of art, science, economics, and every sphere of life that you can say. Today, I like to bring to attention to contribution to the startup ecosystem in GUSDAP. So, so at Gujarat University, our approach to innovation is slightly unique in the sense the mandate given to us to start with sensitizing students, spreading entrepreneurship innovation, and helping them to and but we have taken that GU has taken that in a direction to a different level. How? So our approach is to make it democratization, access to everyone, and making it accessible for the all sections of the startup founders. So how we have done it? First of all, we have a unique model called zero to zero cost. So as you know, starting a business, starting an enterprise takes a lot of money, taking office. But at GUSEC, what we offer zero to zero cost, where if a founder gets selected for his idea, then he gets co-working space free of cost. So there is no equity, unlike other incubator when they incubated. So there is no equity charge for the startup founders. So which is a major benefit. And so inclusive, not in terms only financially, inclusive in terms of say sector. So GUSEC is sector agnostic incubator. And also we try to be inclusive in terms of creating special initiative for gender-based. For example, Hotstart is an initiative for women entrepreneurs. Similarly, we've got VACIC, a initiative for school-going children. So this kind of inclusive program also we have initiated. So this is how we created an innovation cluster at GU, comprising 2 incubators, GUSEC, AIGUSEC, Hotstart, VCIC, and also IDSR, which is a defense-focused sector-specific incubation services providing to startups. Any guess when startup India policy was launched. Correct, 2016. So with the launch of Startup India policy coincided the birth of GUSEC. In fact, Startup India policy was launched in Jan 2016 and GUSEC was born February 2016. And we completed 10 years this year, a decade of support to startup ecosystems. A sector agnostic incubator, and over a decade we have supported 600 plus startups. And we've created many milestones during this journey. Through our startup founders, many of them went on to raise funding. In fact, GUSEC is funded to the extent of 36 crore, and the startups have created 12,000 plus jobs. And startups cumulative revenue is 1,000 crore. So this kind of impact the GUSEC startup ecosystem created over last decade. So when 2019 Atal Innovation Mission came up with we applied for Atal Innovation Mission, and under which we started AIC GUSEC. So AIC GUSEC is sector specific with a focus on health, education, environment, inclusivity. So these are sectors that we focus. Under AIC GUSEC, we have supported 120 plus startups. And we have given funding to the extent of 10 crore. And whereas these startups have raised external funding to the extent of 100 crore plus, which is a commendable achievement, looking at the number of 120 startups and the valuation of around 500 crore plus. As you're talking about the inclusivity, so we started 2019, Start is an initiative to provide a platform to the women entrepreneur to help them, because in startup ecosystem, women entrepreneurs were not properly represented, not only in terms of ideas, also in terms of funding and various other support. To fill in that gap, Start was initiated as a community, and by the third edition, we made it a national initiative by converting it to a platform. In 2022, our president, Dr. Draupadi ma'am, she inaugurated Start platform, and today it has evolved into an incubator come accelerator and a community through which we support women startup, provide accelerator program, which runs for entirely 6 months. In fact, the fifth edition, where we are inviting application, it is in progress. So we have already completed 4 editions, and we have, under this program, around 500 plus women entrepreneurs have got benefited, and many of them featured in the most successful startup across India. There is a call for the nation for the Atmanirbhar in the defense. So our contribution in terms of running a defense accelerator under IDSR. IDSR is a excellent company of Gujarat University, which partner with government of Gujarat and IDST. So under which we provide an accelerator program to the 8 selected defense tech startups, and they get mentoring, they get funding, and all kinds of support. And how to, if they have proven model, then how can they scale up the revenue? So this program will be coming to an end in another 1 month. Under AIC GUSEC, we running a program, Climate Tech Accelerator Program, in continuation with the theme of AIC GUSEC, under which various clean energy, waste management, recycling, so entire green economy based startups, because that is where, though everybody is convinced that we need climate tech startups, but somewhere they need a greater support. It is even more challenging for climate tech startups to come to the market, because economics not very favorable for the climate tech startup. So we're especially running a dedicated accelerator program, and around 25 odd startups are under this accelerator program, and we are helping them with the funding, mentoring, and market access. Vikram Sarabhai Children Innovation Center. This is our initiative for school-going kids. In fact, I'll just share you. Sometime back, we received a call from industry. They're looking for certain startups, and they like the products. And the startups are very historically maybe 4 or 5 years back. When we try to find out all these startups were started by VCIC platform. Over the last 7-8 years, they evolved into product which today is sought by the industries. So it was very heartening. And sometimes when you do this kind of long gestation program, so what do you do under VCIC? We invite school-going children for immersive experience in incubator. We also do an interactive program with startup founders. They share their success stories and they understand what it is like, the startup founders life cycle and startup life cycle as such. And when you see such success stories, it is very heartening for us because we don't know what can impact and how it will create over a period of time. So under VCIC, we have sensitized around 10,000 plus students and 60 plus schools involved, and 150 teachers have been trained. In fact, this program is being run with support of UNICEF. We are currently running a program in especially Narmada district, as per the mandated by UNICEF, where we sensitize the school children about innovation, design thinking, and how to solve real life problems around them. So these are the impact numbers, like entire Geo startup ecosystem, where 700 plus startup has been incubated, around 12,000 plus jobs created. But I like to draw your attention, 130 plus patent filed by our incubator startups, which I think is a significant, because these are not only patents, these are patents which has been commercialized. And the patents which startup founder, you leveraging them to generate revenue. So these are market approved innovations. And out of the 700, 200 plus startups are product based startups. So because building a product is more challenging compared to services. And so apart from this standard impact metrics of an incubator, we also taken the extra initiative like sensitizing students. So we have sensitized around 2.8 lakhs students over last decade through our 800 plus program for students as well as for our startup founders. So when a startup get incubated, so what kind of support? So one of the critical thing required is fabrication, where they can develop their product. So we have got Fab Lab, where they can have access to 3D printers and various other tools. Also access to the laboratory facilities of Gujarat universities, which is very critical. So the R&D facility they can access. And mentoring. So when you start any startup founder, mentoring is very, very critical. Because for a startup, it is how the number of iteration, how it can be accelerated, how fast it can happen. So mentoring is very critical for the iteration, for the repeated iteration, successful iteration, which lead to the conclusion. Infrastructure wise, the startup is accessible. Like for example, this is a part of the incubation facility where they can conduct events, or it can be seminar, can product launch for the even knowledge sessions for startup founders. So these kind of facilities, any startup founder when incubated, they have access to. Now some of our notable startups who have done really well across, starting from health tech to some solar to civic problem solution like showing parking, we here into hearing aid solution, or Alpino, which into food segment, Indisemic into semiconductor. So across all sectors. And how we've done so far with this, we required a lot of partnerships. So thanks to various partners, whether it is a government support, whether it is the Ministry of Science and Technology, or Ministry of Education, or MSME, or MIT Startup Hub, Startup India Seed Fund Scheme. So these are all our partners, and like SSIFE, UNICEF, Meta. We have run accelerator program in collaboration with Meta, and recently, in fact, PNB MetLife also sponsored a program for skilling, which is again run through ACGUSEC. So industry bodies, government bodies, and corporates put together, created a holistic ecosystem for our startup. Would like to. So over to you. Okay. So in fact, we'll start with the senescence.
One thing you can always, I would request one of the GSEC only. Let us include, like 2 weeks in this. One is the student starter policy on that. मैंने बताया ही था कि on this week. And second is, about like space program. What is our, vision for inclusiveness for this kind of segment? I think there are stray cases only as of now. That we need to, define in the subsequent. So that is pay of the way. Shared, like student startup policy, I've already shared with my team. And this today's program, after I've attended it, I think that we should have some specific activities, charted out. I think I hope you can share it with others also. Thank you.
Senescence. There are two starters. One is senescence and second is freeze.
Good afternoon. I'm Gunjan here, and I'm founder and CEO of the Senescence Private Limited. As we know, when we walk, we run. There is a signature walking pattern of every human. So how to get that walking pattern? Then you are a normal or abnormal, or any clinical condition, and how to see is a normal or abnormal way, the way we are walking it. Similar, like we have ECG waveform, that is like unique pattern. But same as we have also a walking pattern that is called, in a clinical condition, they call it a gait analysis. And that's what our startup does. In the last year, Vibrant Gujarat, our Honorable Chief Minister, Bhupendra Patel, launched our product. And since that we are in market now, that was on a national international platform. We are a team of a group of people with clinical expert, and I have done also industry experience. I graduated from IIT Chennai, fellowship from AIMS Medical College, and having in this domain with research and R&D like more than 10 years. And we have an investor, I am GUCON supported, also from the government of DBT state level as well as the central level. And we have Dr. Amol Patel in our team. He was earlier with Indian Olympic team, Americom official, as a boxing team, American official medical doctor in Commonwealth as well as Olympic. And we have other mentors and stakeholders who are working with. So mainly our technology works with the motion sensors like health, sports, wellness, and a new one we are exploring that is also a cybersecurity way. Because if you see sometime the criminals walking, they can have a psychological test, they have another test, but how to walk the criminal is a different way with the psychology. So that can be also detected through a gait analysis. And there are already tested and trial clinical gait analysis done in a cybersecurity level. Apart from that, what our main product today we are going to present is the locomotion disability people have osteoarthritis. More than 230 million people under this umbrella in India. Sports injuries, neurological disorders, and the biggest number is in this is osteoarthritis people. And they have, when age is growing, the walking pattern is changed because of the knee osteoarthritis and knee pain. Similar for the sports category, so I will skip this slide. And currently what they do, when patient goes to the clinic, they have two options, either observational or a clinical gait lab. But in a clinical gait lab, the setup is very few in across India, not even less than 10 gait lab available. Hardly setup, there are less than 10, but the test cost of the setup is around 1 to 1.5 CR, can up to 2 CR, which is very highly expensive. And per test for every test they do, as a normal, if I have to take, it takes 2 hours, which is like very time consuming process, very complex process. So what we have come up with our wearable sensor technology, just you need kind of what size of sensor, put it, ask patient to walk for a few meters and get the data, and clinical gait analysis done within 10 to 15 minutes. We have patents and trademarks already granted. One patent is granted last month, one is in process. This same as for the sports category, on-field, off-field performance levels, ACL injuries that can be also measured and monitored. So it is accurate, portable, comprehensive report is provided. It helps in decision making at a surgeon level also, as well as a therapy level monitoring also. That is provide objective and targeted therapy, like how they prescribe the medicine. Similar way, the therapy can be prescribed from the data. And this is one of the sample report for OA patient pre and post-op surgery. So how the deformity is reduced, even in locomotion disability or the OA level or any neuro condition, how much improvement over time that can be monitored and tracked. One of the case study of the Goa Ranchi baller, and we have helped them without any intervention of the surgical, with the help of the technology and biomechanics analysis, 60% pain got reduced. We are competing with the motion camera systems as well as the video systems, or in a conventional like observation. There is no technology available, but still we are having a technology that can be same accuracy which is provided traditional gate lab with a 98% accuracy, portable, and we can provide the same as parameter of the existing systems. And this product, we have a B2B product. We deal with the hospitals, clinics, centers, and we have two versions. One is subscription version for a small number, and the bigger hospital, we have directly sell one-time unit of the product. And this is my team. We are more than 35-year experience of the total people, and we have vendors and advisors from the industry as well as the ecosystem of the startup and government side. And yeah, we are already in the market, so we are in revenue stage. So anybody interested, you can just meet me and would like to chat for any further discussion. I will be open to discuss. Thank you so much. And thank you so much, you, second year, for giving me the opportunity.
Next, we said D3. D3, yes. D3S. Yeah. 5 minutes. Please stay. Good evening, everyone. First of all, it's first doctor conference that I attend, to beginning with the good morning and ending with the good evening. Right? And it is very difficult to that's in explaining that what I do, especially when your turn is in last. But yeah, I'm taking that in 2-3 minutes. So myself, Dhruv Patel, I am founder and CEO of D3S Healthcare Technology. We started that our journey in 2023 with the small concept that we need to do something in the field of cancer. This is what the statistic since last couple of years, the breast cancer cases is increasing very high. If I'm talking for the, the specifically for the statistic point of view, one who is facing the problem for the breast cancer. If I'm talking for, that's India point of view, since last 5 of the year, that more than 7.8 million women who had diagnosis for the breast cancer. And unfortunately, when she is getting the idea whether she having a cancer or not, she will be reaching on stage 2 and stage 3, which is very difficult for the correct point of that every 4 minutes that one woman is diagnosed for the breast cancer, and every 13 minutes that one woman is lost because of the breast cancer. So we as a DBS healthcare technology that we developed that one of the solutions with the name of VR Scan Light. So this is one of the portable handheld and the DIY kind of devices which is working on the red light technology. So we are used that in a one specific wavelength which can absorb the cancer tissue and it will be making the dark. Now, in the cosmetic point of view, everywhere breast size, shape, and density will differ. So, in the bottom of the first of the key that we wanted to set particular for the brightness of that lights. Further, this device is integrating with the software as well. So, once the screening will complete, the woman will get in the report. So, this is what the first phase of the pilot. Let me show you that in as actual results. So, if you observe that the first image, that woman is doing the skinning by the using of that in our device. Now the result is that if the normal breast is that it is look like this one, and if any kind of abnormality is that it is look like this one, right? So by the naked eye, woman will getting the idea whether she having any kind of abnormality is present in her breast. The second phase that we finish the clinical validations on the first for the 110 patients. So we compare with the gold standard with the existing technology for the sonography and mammography. So of course, my technology is not replacement of the sonography and mammography, but it's the first phase. You can say that in a preventive as well. You can say that in an early detections point of view.
So we finished the clinical validations, like we did the screening first patient through our device, the same patient we did the sonography, and same patient we did the mammography as well. And the sensitivity of my device, which compared to mammography, it is a 94%, and with compared to sonography, it is a 93%. So this is what that in my clinical validations data. Now, once the screening is finished, the woman will getting the report. It is look like this one, where the left side of the three images are there and the right side of the three images are there, right? So this is what the reports will be getting in her mobile. Coming on the another part, which is called the in a compliance. So we got that in a appropriator, as well as we have a certified from the CDSO as well, right? So this is what the compliance point of view. So we have a licensing in the manufacturing point of view. It is a proud moment for me that's in the India in the breast transformations. We are only one to having this licensing for the manufacturing as well as in the sales point of view. Presently, we have a two model. That's one is only devices and another for entire setup, which is used for the in a B2B point of view. Coming on the stage three, till the date that we screen more than 8,000 plus screening, we already finished in specifically for the rural area, right? CSC level and the PSC levels as well. And then the recently, last couple of months back, that we started the screening in the urban as well with some universities, some colleges, some society clinics as well. So with the support of some couple of foundations with the Azira foundations and all, right? Where we screen that in 1,000 plus clinic. And this is what that our first success story. Out of that, so all the screenings that we found more than 120 plus abnormality images that we detected. Further, it is confirmed through the sonography and mammography as well. So this is what that the screenings models as well. Right now, we have a presence in the Gujarat, Maharashtra, Madhya Pradesh, and Odisha as well. So this is what the one thing. We launched this device in a couple of years back through that our ex health minister of the Gujarat, and this is what some market projections and all. We received some couple of achievements and award from the state government, central government, even though we got the very good supports in terms of the mentorships and the funding through GUSEC as well. This is what that our product showcase and the interactions with the governments as well, because this product having an impact in B2C as well as B2B, and the third one for the B2G as well. So this is what that our showcase media and the interactions for not only the boundary with the Gujarat, but how was it out of the Gujarat, as well as the global level presence as well. We are continuously increasing that our awareness among the that woman as well as the facilitator who is that the ground level they are working to domain in the field of breast cancer and the breast cancer awareness and all. So this is what that awareness and the interactions with the different expo and the exhibitions and all. This is what some awareness and there's interactions with the Ministry of External Affairs teams from the outside of the India as well. And through that, right now we have a presence in the UK as well as in the Australia also. So this is we also saw for the defense for this stadium's point of view. This is some price and the media coverage is. And this is what the social motto in coming period of the time that we need to achieve that in a 1 lakh plus screening for the breast cancer and all. For that, we are doing that in a joint campaigning with the Gujarat Cancer Society as well as Gujarat CSR Authority as well. Thank you.
So how we analyze this or images?
So, of course, the first one by the naked eye, that woman will getting the idea if any kind of abnormality is present or
How
not.
we
And we have some images which they can supposed to keep as a references. That is number one. And second, those images is go with the radiologist doctor also. So radiologist doctor is analyzed of that. And our third phase that we are planning to integrate AI. So this is what the third level of it. So above 4 mm, any of the abnormality can able to detect through my device. Because in the breast, there is a no bond is there, right? So woman need to keep the device under the breast like that, then the breast will glow, right? Then we identify the three different quadrant for the left side, top side, and the bottom side kind of stuff, like a swastik, right? And then after that, through that in a mobile camera, they need to capture the images, right? And once the image is captured, whatever the abnormality is there, that will be capturing in the mobile, as well as in the naked eye also seem to be getting the idea, okay, here that abnormality is present, I need to go with that further diagnosis for the sonography and mammography as well.
I think these wonderful products you need to friends all the moments.
Yeah. Yeah. Yes, exactly. Yeah. Thank you. Thank you very much.
Thank you, sir. Now, after the heavy informative session, let us lighten the mood. I would like to welcome Shri Vinay Dave on the stage. He is a renowned writer, lyricist, humorist, and also performer. And we are or knowing one very good song that is called Mari Marji or Meri Marji from the movie Gambler. And he is the famous lyricist of that song. And he's also having multiple achievements in his portfolio. He's lyricist of many Gujarati movies as well. So I would like to welcome Shri Vinay Bhai Dave on the stage, sir. Please welcome.
Yeah. Keyword. Yes, subscribe our request in short notice. તમે ગોવિંદાના હલો તમે ગોવિંદાના પિક્ચર જોયા હશે પેલું માથું મિલી મુજે રસ્તે में પછી મેરી મરજી એ બધા સોંગ્સ એમણે લખેલા છે અને ગમત ગુલાબભાઈ ની ગુજરાતી બહુ ફેમસ હ્યુમર સિરિયલ હતી ઇઝ અ ડાયરેક્ટર ઓફ ધેટ સો Vinay is very good friend of me. He's a good director. Good overseas and good director. So Vinay. Hello. એટલે ગંભીર વાતો પછીથી લવારી કરવાની મારે આવે છે એવું છે પણ આગળના મેં કેટલાક સેશન જોયા અને એની અંદર બધા એક જે કંઈ પણ રજૂઆત કરનારા હતા ને એક ચેર કરવા માટે કોઈકને રાખ્યા હતા અહીંયા આગળ હું ચેરમેન થઈ ગયો એવું થયું છે પણ મારે એક રિક્વેસ્ટ કરવાની રાજભાઈને મારા સેશનમાં ચેર કરવા માટે ખાસ કહું છું મારી સાથે આવે કારણ કે એક નાનું તોફાન અમે બે સાથે મળીને પણ કરવાના છીએ અને હું આઈ થિંક બધાને ગુજરાતી સમજાય છે ને હે ને અને મને બીજી ભાષા નથી આવડતી પહેલેથી કહી રાખું છું કે ગુજરાતીમાં આપણે બધા વાત કરીશું અને હ્યુમરની કોમેડીની જે કંઈ પણ વાતો કરવાની છે એ કરીશું સૌથી પહેલા તો આપણે આ ટેલિમેડિસિનનું રાજભાઈએ મને કહેલું હવે મને એમ કે આ કે પેલી ફોન કરીને દવા મંગાવવાવાળી ઘટના હશે આ કે આપણે પેલા ફાર્મસી વાળા અને એ બધા હોય છે એ લોકોનું સંમેલન છે મને કે ના એવું નથી ડોક્ટરો છો એ આવી રીતના ભેગા થવાના છે અને તેની મેડિસિન એટલે વિડીયો કોન્ફરન્સિંગ દ્વારા પેશન્ટ્સને એ બધાને જોવાનું ને એ પ્રકારની એમની ટ્રીટમેન્ટ કરવાની ને એ પ્રકારની આ જે કામ કરનારા છે એ ડોક્ટરોનું છે સાથે સાથે જે કંઈ પણ મેડિકલ ફેસિલિટીઝ છે નવા નવા એની અંદર જે કંઈ પણ સાધનો ઉપકરણો શોધાયેલા છે એની વિશે પણ લોકોને જાણકારી માહિતી આપવા માટેનો આ કાર્યક્રમ છે પછી મને મયુરભાઈએ બ્રોશરનો એક ફોટો મોકલ્યો રજિસ્ટ્રેશન કમ્પલસરી 1000 રૂપિયા લખ્યા હતા એટલે હું તો ટેન્શનમાં આવ્યો મારે ક્યાં કરવાનું જવું હતું એટલે આપવાના નીકળ્યા તો મારે તો ઊંધું થયું આ તમારે રજિસ્ટ્રેશન નથી કરાવવાનું તમને એમને આવજો કે વાંધો નહીં એટલે આ પરિસ્થિતિ કન્ફ્યુઝનમાંથી હું આવ્યો છું અને આમે ખાસો મને રાજભાઈ તો જમવાના ટાઈમે બોલાવ્યો હતો કે આવી જજો પણ આમ બ્રાહ્મણ ઘેર ખાય ઝેર ખાય ઘેર ના ખાય એવું મેં આજે ખોટો પાડી દીધું હું ઘેર ખાઈને આવ્યો પણ 3 વાગ્યાથી આવીને બેઠો એટલે આમે ડોક્ટરોની ક્લિનિકની અંદર લાંબા ટાઈમ સુધી બેસવાની આદત વાળો છું એટલે અહીંયા આગળ બેસવાની મને કંઈ તકલીફ પડી નથી પણ કાર્યક્રમમાં આપણે જે હ્યુમરની વાતો કરવાની છે એનાથી શરૂ કરી અને આમ તો રાજભાઈને મેં કહી રાખેલું કે તમારે ખાલી બસ એટલું કહેજો મને કારણ કે હું તો કલાક 2 કલાક સુધી ડાયરેક્ટ બોલ્યા કે વિવિધ પ્રકારની વાતો વાળું છે મારું કામ તો જે કંઈ પણ મારે તમને કહેવું છે રજૂઆત કરવી છે એની શરૂઆતની અંદર થોડી ઘણી હું વાતો તમને કહું આમ છે ને હું બીકોમ એમકોમ એલએલબી એડવોકેટ એ બધું ભણેલું છું અને અચાનક જ ફંડાઈને આ ગીતકાર લેખક અને અભિનેતાને કોલમિસ્ટ છાપાની અંદર બધી કોલમ લખતો થઈ ગયો એટલે હું જે કંઈ પણ બોલું છું એ બધું મારું ક્રિએટ કરેલું લોકો પેલા જોક્સ ને મિમિક્રી કરતા એવું નથી કહેતો એટલે હું મારું જે મટીરિયલ છે મારે સાથે રાખીને હું કહીશ એટલે ફાઇલમાંથી જોઈને બોલીશ તમને વાંધો હોય ના હોય હું બોલીશ એ જ રીતે કારણ કે આટલું બધું યાદ રહેતું હોય તો હું ડોક્ટર હું શરૂઆતની અંદર આપણે ડોક્ટરના પ્રોફેશન વિશેની કેટલીક મારી જે વાતો કહેવી છે તમને એ તમને રજૂ કરવી છે મારે કે ડોક્ટરને આમ તો એવું કહેવામાં આવે છે કે એ પ્રોફેશન જે છે
એ આપણે આમ સિરિયસ પ્રોફેશન ગણાય અને ડોક્ટર પોતે પણ બધા સિરિયસ હોય છે. ડોક્ટરને પ્રેમ થાય તો કેવી રીતનો પ્રેમ થાય? જ્યાં ધારો કે વકીલનો કાર્યક્રમ હોય તો એમના માટેની સ્પેસિફિક હું હ્યુમર ક્રિએટ કરતો હોઉં છું. રાજભાઈએ મને કીધું આ ડોક્ટર્સનું એનું છે તો એના માટેની આપણે કંઈક વાતો કરીએ. તો ડોક્ટરને પ્રેમ થાય તો શું પરિસ્થિતિ થાય એના ઉપરનું મેં એક હાસ્ય ગીત બનાવેલું છે એ જ મારી સમક્ષ રજૂ કરવા જઈ રહ્યો છું. બેઝિકલી આ એક મનહર છંદ છે કે ઊંટ કહે આ સભામાં વાંકા અંગવાળા ગુડા એ જે છંદ છે એના ઉપર બનાવેલું ગીત છે. પણ આપણે સહેજ પણ ગંભીરતા રાખ્યા વગર ડોક્ટરના પ્રોફેશનને કે ડોક્ટરને પ્રેમ થાય તો શું પરિસ્થિતિ થતી હોય છે કે ડોક્ટરને જ્યારે ક્યાંક પ્રેમ થઈ જાય છે, ડોક્ટરને જ્યારે ક્યાંક પ્રેમ થઈ જાય છે ત્યારે ત્યારે રોમેન્ટિક કોમેડી સર્જાય છે. ડોક્ટરને જ્યારે ક્યાંક પ્રેમ થઈ જાય છે ત્યારે ત્યારે રોમેન્ટિક કોમેડી સર્જાય છે. ડોક્ટર થી લવ લેટર એવા તો લખાય છે, પ્રેમિકા એ ઉકેલવા કેમિસ્ટ પાસે જાય છે. ડોક્ટરનો પ્રેમ પત્ર જો ઉકેલાવવો હોય પ્રેમિકાને તો કેમિસ્ટ પાસે જવું પડે. રાજભાઈએ મને એક વખત એમના ઘરે બોલાવ્યો હતો અને મને કે આ એડ્રેસ પર આવી જજો, એમણે મને લખીને આપેલું. હું પછી રસ્તામાં કન્ફ્યુઝ થયો એઝ યુઝ્યુઅલ જે રીતના લોકો પૂછપરછ શરૂ કરે એટલે મને જોયું આ ડોક્ટર છે એટલે કેમિસ્ટ પાસે જવાનું. એટલે કેમિસ્ટની પાસે ગયો. ડોક્ટર રાજભાઈએ લખીને આપેલું એડ્રેસ લઈને મેં એને બતાવ્યું એટલે એને તરત મારી સામે જોઈને હસ્યો અને પછી અંદર જઈને સેલ્ડાના ફિલ 100 આંખ મારી મને આપી. મને કે જલસા કરો. એ મેં શું આપ્યું ભાઈ તમે? તો પછી મેં આગળ જઈને પાનવાળાને આ ચીઠી આપી રાજભાઈ વાળી. તો પાનવાળાએ મેં બનારસી નવરત્ન 120 પાન 4 પેક કરીને આપી દીધા. કેમ આજે 4? મેં કીધું ક્યાં એવું? પોલીસને મેં કીધું પૂછવા છે તો પોલીસે તો ધોળા કાઢીને ગાળો બોલી મને. મેં કીધું આ લખ્યું છે શું હમણાં? પછી મેં કીધું છોડ જવા દે ને ફોન જ કરવા દે. તો ફોન કર્યો. મને કહે સામે જ છે જુઓ જ ખરા, રોડ ક્રોસ કરીને પેલી બાજુ હું ઊભો છું. નજીક જ હતો હું ક્યાં ફર્યા કરતો. મેં એમને કહ્યું મેં કીધું રાજુ તમારા અક્ષર જુઓ યાર, તમે જે એડ્રેસ લખીને આપ્યું તમે આવું થયું. એટલે અરે યાર ખોટું અપાઈ ગયું. આ તો 7નું લિસ્ટ છે, મારે 7 માટે ડેટ મને આપ્યું તો એ છે. એટલે એકચ્યુઅલી શું હતું એ મને આજ સુધી નહોતું સમજાયું. એટલે ડોક્ટરથી લવ લેટર એવા તો લખાય છે, પ્રેમિકા એ ઉકેલવા કેમિસ્ટ પાસે જાય છે. પ્રેમિકાને ઘરે મળવા ડોક્ટર જો જાય છે, પ્રેમિકાને ઘરે મળવા ડોક્ટર જો જાય છે ત્યારે બોલે હોમ વિઝિટના 1000 રૂપિયા થાય છે. પ્રેમિકા જો કહે મને ધક ધક થાય છે, પ્રેમિકા જો કહે મને ધક ધક થાય છે ત્યારે એનો કાર્ડિયોગ્રામ ઈસીજી કઢાય છે. એમ કે અને આંખમાં પરોવી આંખ પ્રેમિકા જો ગાય છે, આંખમાં પરોવી આંખ પ્રેમિકા જો ગાય છે, મારી આંખમાં ડિયર ફોટો તમને શું દેખાય છે? આંખમાં પરોવી આંખ પ્રેમિકા જો ગાય છે, મારી આંખમાં બોલો ડિયર તમને શું દેખાય છે? ડોક્ટર આંખ જોઈ બોલે સાપ વંચાય છે. ડોક્ટર આંખ જોઈ બોલે સાપ વંચાય છે. હિમોગ્લોબિન ઓછું છે ને કેટરેક્ટ દેખાય છે. એને ત્યાં આગળ બધા રોગ દેખાય છે પ્રેમીને. અને છેલ્લે કહે છે કે વાત સાંભળીને પછી પ્રેમિકા બગવાય છે, વાત સાંભળીને પછી પ્રેમિકા બગવાય છે. સીયુ કહી ડોક્ટર હતો આઈસીયુ માં જાય છે. એટલે આ પ્રેમીની ડોક્ટરની કથા જે છે એ આવા પ્રકારની કથાઓ છે. પણ એક આ ટેલિમેડિસિન વાળી જે ઘટના જે કહી ને એમાં એ મને પછીથી એમણે ગયા પછીથી મને ખ્યાલ આવ્યો કે આ પ્રકારની બધી જે દૂરથી પેશન્ટો સાથેની એની ટ્રીટમેન્ટ લઈને એ બધા પ્રકારની વાતો કરવાની છે. તો એમાં એ પરિસ્થિતિની અંદર આમ અલગ અલગ પેશન્ટોને જોવાના અને ટેલિફોન પર કે વિડીયો કોન્ફરન્સિંગ કરવાની એની અંદર એક ફાયદો ડોક્ટરો માટે હું તમને કહું મને એવો દેખાય છે ડોક્ટરો જ્યારે ટેલિમેડિસિન થી પેશન્ટને જોતા હોય ત્યારે અમે ડોક્ટરોને જોયું છે કે એકદમ સરસ મજાના તૈયાર થયેલા ડોક્ટરને જુઓ તમને ખ્યાલ આવી જાય કે આ ડોક્ટર છે. એટલે એમ વ્યવસ્થિત તૈયાર થયેલા હોય કે એમના હેરસ્ટાઇલ ચશ્મા બધું એકદમ સુપર હોય અને એકદમ સોબર પર્સનાલિટી દેખાય. પણ ડોક્ટરને જ્યારે ટેલિમેડિસિન હોય ત્યારે આ ટેન્શનમાંથી મુક્ત થઈ જાય. ઉપર ખાલી શર્ટ ના ટાઈ પહેરીને બેઠા નીચે બરમુડો પહેરીને બેઠો હોય તોય ચાલે. અડધા જ દેખાવાના છે ને. પણ એક બીજું એક એમની સાથે સાથે એવું પણ થઈ શકે છે કે ડોક્ટરને ટેલિમેડિસિન ની અંદર જ્યારે પેશન્ટ્સને જોવાના થાય ત્યારે એમને જે કંઈ પણ પેશન્ટની સાથેની માથાકૂટ વાળી એમના ઘરના ફેમિલી મેમ્બર્સ સાથેની જે કંઈ પણ પથારી ફેરવનારી ઘટનાઓ છે એ બધામાંથી મુક્તિ મળી જતી હોય છે. કારણ કે પેશન્ટો ડોક્ટરની સાથે કેવું કેવું વર્તન કરતા હોય છે અને કયા પ્રકારની વાતો કરતા હોય છે એ બહુ ઇન્ટરેસ્ટિંગ હોય છે. આપણે ત્યાં આગળ પેશન્ટ ડોક્ટરની સાથે જ્યારે વાત કરતા હોય ત્યારે એમની ટિપિકલ જાર્ગન હોય છે અને એ તમને એ જોતા એટલે એમની સાથે વાત કરતા જ ખ્યાલ આવે. અમુક જણા ડોક્ટરની સાથે વાત કરતી વખતે શું કહેતા હોય છે કે મને સાહેબ તમે જે આ દવા આપી છે ને એ એનાથી રિલેશન થાય છે. રિલેશન થાય એટલે કઈ સમજાવ્યું નહીં. એટલે હું એ કહેવાય એવું માંગતો મને રિએક્શન આવે છે. પણ એના શબ્દોની અંદર જ્યારે કન્ફ્યુઝન થતું હોય મારા એક મિત્રના ફાધર છે એ કાયમ એસિડિટી ને એસીડીસી છે પેટમાં એવું કહેતા હતા. મારા પેટમાં એસીડીસી થાય. અચ્છા સૌથી વધારે કોરોના વખતે રાજભાઈ જે ફોન પરથી એમણે અમારા આખા ફેમિલીની ટ્રીટમેન્ટ પણ એમણે આપેલી અને એ ઘેર બેસીને એમણે ઘણા બધા પેશન્ટોને એમને એ ટ્રીટમેન્ટ આપેલી. એની અંદર જ્યારે એ કોરોના ચાલતો હતો ત્યારે એક જણાએ મને એવું કીધું હતું કે કોરોનાની અંદર સૌથી પહેલા તો તમારે આરટીઓ પીસીઓ કરાવી આવવાનું. આરટીઓ પીસીઓ એટલે શું? એટલે હું પેલું આરટીપીસીઆર જે હતું એને આરટીઓ પીસીઓ કહેતા હતા. પછી સૌથી અદ્ભુત આપણે ત્યાં આગળ ડોક્ટરની સાથે વાત કરતા ને ત્યારે કે સાહેબ મને છે ને મોડો જીવ થાય. એટલે એક્ઝેક્ટલી શું થતું હોય મોડો જીવ એટલે શું એ તમે કહો અંગ્રેજ ડોક્ટર ના કહો તો ગાંડો થઈ જાય. એને ખ્યાલ જ ના આવે કે મોડો જીવ નામની ઘટના શું. અને સૌથી બેસ્ટ પેટમાં પ્રોબ્લેમ હોય ને ત્યારે કે પેચોટી ખસી ગઈ. તો પેચોટી તમારા મેડિકલ અંદર છે પેચોટી છે. પેચોટી નામની ઘટના શું છે મને સમજાવો કે. અચ્છા એની અંદર પાછા દોરીથી આમ ચોટી પર દોરી મૂકે અને ખભે એક બીજો ખભે એમ દોરીનું માપ કાઢે પછી એક લાંબી ટૂંકી થાય કે આ સાઈડ પેચોટી ખસી ગઈ. અને પછી પેટ ઉપર કઈ કાચનો ગ્લાસ કે લોટો મૂકીને ગોળ ફેરવીને હવે સેટ થઈ ગઈ. સર પેચોટી છે ને કોઈ મેડિકલ સાયન્સ ની અંદર ક્યાંય આવેલું નથી. ઘણા શું કહે છે કે સાહેબ મારે છે ને આ બધું છે ને એટલે મારે ડીપી નો પ્રોબ્લેમ. ડીપી એટલે તો પેલી ઇલેક્ટ્રિસિટી ની હવે ડીપી નો પ્રોબ્લેમ હોય એક્ઝેક્ટલી. પણ એબીસીડી ની અંદર કંઈ પણ ગોઠવી દે આગળ અને બેસ્ટમાં બેસ્ટ એક જણાએ મને કહ્યું મારા ફાધરને ગ્લુકોઝના બિસ્કિટના બાટલા ચડાયા. ગ્લુકોઝના બિસ્કિટના બાટલા ના બની ગ્લુકોઝના બાટલા ચડાવ્યા ત્યાં સુધી બરાબર. આ પ્રકારના પેશન્ટ સાથેના જે કંઈ પણ સંવાદો જે છે એનાથી તમને મુક્તિ ટેલિમેડિસિનની અંદર મળે એ મને ખાતરી છે. આજે મેં તમને કવિતા કહી એવી થોડી નાની લઘુ શાયરીઓથી તમને ડોક્ટર્સ માટે મેનિપ્યુલેટ કરી છે. એમાં કહું કે પ્રેમના પથ પર તકલીફોના દર્દ આવશે. પ્રેમના પથ પર તકલીફો અને દર્દ આવશે. મારું માનો ત્યાં મેડિકલ સ્ટોર કરો બહુ ચાલશે. અને બીજું એક મેડિકલ તમને એ શાયરી કહું તમને કે હાથ પગ સ્તબ્ધ થયા સ્થિર થઈ ગઈ દુનિયા. હાથ પગ સ્તબ્ધ થયા સ્થિર થઈ ગઈ દુનિયા. રિપોર્ટ જોઈ ડોક્ટર બોલ્યા આ ભાઈને તો ચિકન બોલ્યા. અને નજરોથી નજર મળી ને દિલને પાંખો આવી. નજરોથી નજર મળી ને દિલને પાંખો આવી. બીજે દી સવારે જોયું અલ્યા મને તો આંખો આવી. કંજક્ટિવાઇટિસ જેને ઘણા કંજક્ટિવાઇટિસ કહેતા હોય છે. પણ ડોક્ટરની ઉપરની એક શાયરી તમને કહું કે ભણી ગણીને ડોક્ટર થઈને કાઢ્યા શું મેં કાંદા. ડોક્ટર પોતે જ કહે છે કે ભણી ગણીને ડોક્ટર થઈને કાઢ્યા છું મેં કાંડા, આખો દિવસ લોકો મળતા બધે બધા માંદા. ભણી ગણીને ડોક્ટર થઈને કાઢ્યા છું મેં કાંડા, આખો દિવસ લોકો મળતા બધે બધા માંદા. દુનિયાને સાજી કરવામાં મારા તૂટ્યા સાંધા, દુનિયાને સાજી કરવામાં મારા તૂટ્યા સાંધા. 12 મહિના બિઝી રહેતા ઘરમાં થઈ ગયા વાંધા. ડોક્ટરની આ કાયમની માથાકૂટનો પ્રોબ્લેમનો કે જે ફેમિલી લાઈફ જે એમની હેવાયર થતી હોય છે એ છે. આ ટેલિમેડિસિન ની અંદર એ એક ફાયદો થાય તમને કદાચ કે વિઝિટમાં જે દોડાદોડી પણ એની સાથે તમારા પર કદાચ ઘરની અંદર જ કાયમ રહેવાનું હોય તો રિસ્ટ્રિક્શન આવી જાય એવું બને. પણ આ પ્રકારની મેડિકલ થોડીક શાયરીઓ કહીને છે એટલે મારી એક ફેવરેટ શાયરી એવી છે કે આવું થયું નથી કદી કાળમાં, આવું થયું નથી કદી કોઈ કાળમાં, વંડી ઉપરથી કૂતરું કર્યું કપાળમાં. સિચ્યુએશન એવી છે કે માણસને વંડી ઉપર બેઠેલું કૂતરું કપાળમાં કઢી ગયું કે વંડી ઉપરથી કૂતરું કર્યું કપાળમાં. અને અત્યારની જે પરિસ્થિતિ છે એના માટે મેં એક લખેલું છે જે છાપામાં એમાં થોડા વખત પહેલા આવેલું કે પેટ્રોલના ભાવ વધે છે એક દી આવશે એવો વખત, પેટ્રોલના ભાવ વધે છે એક દી આવશે એવો વખત, 10 લીટર પેટ્રોલની સાથે ગાડી મળશે મફત. તો આ પ્રકારની બધી તોફાની વાતો જોક શાયરીઓને કરી. પણ રાજભાઈને ચેર પર એટલા માટે રાખેલા કે તમે બધા જ જાણો છો કે રાજભાઈ બહુ સરસ ગાય છે. એ ગાય છે હું બળદ છું આમ એવી રીતના કરીએ તો. પણ એ એમના કેટલાક ગીતો એને ગીત ગાવાનું દઉં પછી એની સામે કવિશ્રીનો વાહિયાત એક એની ભયાનક એની સામે પેરોડી બનાવી છે એ આપણે જરાક માણીએ. તો રાજભાઈને ઓરિજિનલ ગીત ગાવાનું કહીશ અને હું એની સામે એની પેરોડી કહીશ. હેલો, વિનુભાઈ પેરોડી સોંગ મને માસ્ટર છે તો ગીત આપો ચલો જોઈએ કેવું. એક ગીત છે દિલ તો પાગલ હે નું ટાઇટલ સોંગ છે. હેલો, હા એ આપણે જો લાઈનમાં તો પેલું 20 લીંગ આવશે. હા દિલ તો પાગલ હે એનું ટાઇટલ ગીત તમે ગાઓ. ઓકે એની પેરોડી વર્ઝન હું કહીશ. ઓકે દિલ તો પાગલ હે दिल तो पागल है दिल दीवाना. हेलो, पहली पहली बात मिलाता है कहीं सीने में फिर आग लगाता है धीरे धीरे विश्वास लगाता है कोई जब हंसाता है वही रुलाता है दिल तो पागल है दिल दीवाना दिल तो ભાઈ આનું મને સુનીલું લાગે. મેં કવિ વિનો વાહિયાતનું એનું વર્ઝન જે છે એ આ છે કે ટ્રમ્પડો પાગલ છે ટ્રમ્પડો ગાંડો છે ગલીનો ગુંડો છે મવાલી ભૂંડો છે બેફામ બની લગાડે છે ટેરિફ ક્યારેક વધારે ઘટાડે છે નોબેલ પ્રાઇઝ લેવા એ કાઢે છે ગાંડા મધ્યસ્થી બનવા બરાડે છે મોદી ક્યાં ગાંઠે છે પુતિન તો ભાંડે છે સુનીને ક્યાં સાંભળે છે ત્રંપડો ભાંભરે છે ત્રંપડો પાગલ છે ત્રંપડો ગાંડો છે. હવે બીજું એક સરસ મજાનું ગીત છે દર ફિલ્મ નું ગીત છે જાદુ ગાવ સાહેબ. તારાનો બહુ સરસ સોંગ છે. હા જાદુ તેરી નજર खुशबू तेरा बदन जादू तेरी नजर खुशबू तेरा बदन तू हाँ कर या ना कर तू हाँ कर या ना कर तू है मेरी વાહ, હવે તમે ભૂખા હતા. અને ઘરમાં શેઠ અને નોકરની વાત થતી હોય તો એ કેવી રીતના વાત થાય એનું એક પેરોડી વર્ઝન છે. આદુ થોડી સાકર પાણી નાખી ગરમ કર. આદુ થોડી સાકર પાણી નાખી ગરમ કર. તું ચા કર મારા માટે ચા કર. તું ચા કર જલ્દી કર. તું છે મારો ચાકર. તું છે મારો ચાકર. તાજું દૂધ વાપર. નાક ચાને ગરમ કર. કપ સાફ કર એમાં ચા ભર. તું ચા ભર જલ્દી કર. તું છે મારો ચાકર. તું છે મારો ચાકર. અને એક ખૂબ જ જાણીતી ઘટના ઉપરનું પેરોડી સોંગ તમને ઓરિજિનલ સોંગ ની સાથે એ બે લાઈન છે એટલે કહી શકાય. તમે બધાએ કોરા કાગળનું ટાઇટલ સોંગ સાંભળ્યું છે. मेरा जीवन कोरा कागज कोरा ही रह गया. આ ખ્યાલ છે તમને સૌને. આનું પેરોડી વર્ઝન કવિ શ્રી ધીરુ વાહિયાતે કેવું બનાવ્યું છે? ઘટના તમને તરત જ યાદ કરાવી દેશે. કાળા રૂપિયા થયા કાગળ થોડા ન સહી શક્યા. કાળા રૂપિયા થયા કાગળ થોડા ન થઈ શક્યા. દાઢીવાળા કાકા બોલ્યા સૌ સલવાઈ ગયા. 36 રૂપિયે ટાળા 36 રૂપિયે રાજામાંથી માગણ થઈ ગયા. ડિમોનેટાઇઝેશન અને ધુરંધરની અંદર કાકાએ કેમ કર્યું હતું એના વિશે પણ માહિતી આપેલી છે. તો આ બધી પેરોડી વર્ઝનની મેં તમને વાત કરી. અલગ અલગ પ્રકારના જે કે ઓરિજિનલ ગીત હોય એને પેરોડીની અંદર કઈ રીતના કન્વર્ટ કરવા. સૌથી પહેલા તો અહીંયા આગળ હું આવ્યો ત્યારે એક ઈસરોના સાહેબ હવે હાજર છે કે ક્યાં મને ખ્યાલ નથી. હાજી. તો ઈસરો એ અહીંયા આગળ જે આપણા ટેલિમેડિસિનના કામની અંદર ખૂબ મોટું પ્રદાન કરેલું છે. એમને વાતચીત કરી ત્યારે પણ આપણે સાંભળ્યું અને સ્લાઇડ્સ સાથે પણ હું અહીંયા એટલા માટે એમને યાદ કરી રહ્યો છું કે ગુજરાતનું જે કંઈ પણ ટેલિવિઝન અને ફિલ્મનું ક્ષેત્ર છે એના દેશની અંદર ઈસરો રહે. ઈસરોએ ટેલિવિઝનની શરૂઆત જ ઈસરોએ શરૂ કરી આપણે અહીંયા આગળ અમદાવાદની અંદર પીજમાં જે સ્ટેશન છે. એટલે હું એમ કહી શકું 100 માંથી 99% એવા માણસ 99% એક્ટર છે કે રાઇટર્સ છે કે પરફોર્મ કરનારા ડિરેક્ટરો કે એના આસિસ્ટન્ટો કોઈ ઈસરોમાં ટ્રેનિંગ લીધી છે અને એ પછી જ આગળ આવ્યા છે. એટલે ગુજરાતની મનોરંજનની ફિલ્મની ટેલિવિઝનની ઇન્ડસ્ટ્રી છે એમાં પણ ઈસરોનું ખૂબ ટેલિવિઝનમાં છે એ તો દેખાય છે. એમણે બહુ સરસ વાત કરી પણ આ દેશની અંદરની વાત છે એ તમને ખાસ રજૂઆત તમારી સમજ કરવી હતી કે ઈસરોએ અમને લોકોને પણ આટલો જ અમારા લોકોને તમે બહુ વર્ષો પહેલાના કોઈ મિત્રો હશે તેમણે અમે ના મારી ઘોડીને ગામડું જાગે છે એ પ્રકારના જે કંઈ પણ કાર્યક્રમો આવતા હતા ગામ એ રૂરલ ને ત્યાં અર્બન ને બેને ભેગા કરતા પ્રોગ્રામ્સ બનતા હતા. એને ઈસરોથી અમે લોકોએ શરૂઆત કરી. આ ઈસરોની વાત પણ હમણાં ટેલિમેડિસિનની અંદર સૌથી અગત્યનું ફોર્મેટ જે છે એ મોબાઈલ છે. જે મોબાઈલથી સૌથી વધારે લોકોને એટેચમેન્ટ અને કનેક્શન આપવાનું કામ કરે છે. પણ મોબાઈલ છે ને એ આમ બહુ મજાની ઘટના છે. તમને ખાસ મજાની વાત એ કહું કે મોબાઈલ છે, પછી લેપટોપ છે, ટેબ્લેટ છે, કમ્પ્યુટર છે, આ બધી વસ્તુઓની શોધ માણસનો સમય બચે એના માટે થઈ. આની અંદર સૌથી વધારે સમય આની પાછળ આપણે બગાડીએ. આ જ બધા જે છે ગેજેટ્સ છે એ સૌથી વધારે તમારો ટાઈમ બરબાદ કરે છે અને એમાં પણ સૌથી વધારે હેરાન કરનારી તકલીફ આપનારી ઘટના હોય તો ટેલી માર્કેટિંગ વાળાના ફોન. તમને કહું, આ કાકાની પહેલાની સરકાર 14 પહેલાની સરકારની કેબિનેટ મીટિંગ ચાલતી હતી. કેબિનેટ મીટિંગ ની અંદર ફાઇનાન્સ મિનિસ્ટરને ટેલી માર્કેટિંગ વાળાનો લોન માટે ફોન ગયો. આ છાપામાં આવેલી ઘટના. આપણા ફાઇનાન્સ મિનિસ્ટરને લોન એટલા લુંગી વાળા તો આય પાડવા તૈયાર નથી કહેતા. એટલે કોકે કોણી મારી દીધું મેડમ બીજાએ કે પછી એના કેન્સલ રાખી, બાકી તો લઈ લેવાના હતા લોન. એટલે આવા પ્રકારના ટેલી માર્કેટિંગ વાળાના એ લોકો ક્યાંય પણ તમે ક્યાં છો એની સાથે એને લેવા દેવાનું તમને પૂછે નહીં. એ સીધી એની જે એ પેલા કેસેટ વગાડવા માંડે એની સીધે સીધું એનો તૈયાર કરેલી સ્ક્રિપ્ટ ફટ દઈને બોલવા. એટલે હવે એની સામે થાય છે શું કે લોકો અકળાઈ જાય, ગુસ્સે થઈ જાય, બૂમો પાડવા માંડે. હવે હું કીધું ફોન ના ખબર નથી પડતી ને ક્યાં છો ખબર રાડા પોતાનો મૂડ ખરાબ. એવું કરવાની જરૂર. ફોન તમારો છે, તમારા રૂપિયા તો જતા નથી. અમદાવાદી સ્ટાઇલથી વિચારો, તમે એમાંથી મનોરંજન કેવી રીતના મેળવી શકો? ટેલી માર્કેટિંગ વાળાના ફોન તમારા ઉપર આવે અને તમે એમાંથી મજા કઈ રીતના લઈ શકો? ધારો કે તમારા ઉપર ટેલી માર્કેટિંગ વાળાનો કોઈનો ફોન આવે, કાર્ડ વેચવું છે. नमस्कार सर, हम बोगस बैंक से बोल रहे हैं, क्या आप हमारी कंपनी का क्रेडिट कार्ड लेंगे? हमारे कबीले का उसूल है, हम क्रेडिट कार्ड नहीं देते. झिंगालाला झिंगालाला हुर्र, झिंगालाला झिंगालाला हुर्र. પેલા થતા ક્યાં લાગ્યો? આદિવાસી જ્યાં પેલા તો झिंगालाला નહીં કોણ ભાડા લઈને ભૂગે પાંદડા પહેરીને ફરતા હશે એવું झिंगालाला કહે છે. अच्छा, તમને कोई फिजिकल प्रॉब्लम की बात? नमस्कार सर, हम बोगस बैंक से बोल रहे हैं, क्या आप हमारी कंपनी का क्रेडिट कार्ड लेंगे? ना भाई ना ले भाई. કેમ છે? ક્રેડિટ કાર્ડ લઉં છું મને કબજિયાત થઈ જાય છે. શું વાત કરો? હા, 3-4 દાડા બધું બંધ થઈ જાય. પેલા થાય કે આ લે તો એને થાય છે હું તો 12 વર્ષથી વેચું છું માટે તમારે ઇન્ટ્રો થઈ જશે. તમારે કોઈ पर्सनल फैमिली प्रॉब्लम है ना क्या? नमस्कार सर, हम फालतू बैंक से बोल रहे हैं, क्या आप हमारी कंपनी का क्रेडिट कार्ड लेंगे? ना पैसा क्रेडिट कार्ड मारी भाई ने पहली बार 500 में पूरी करो बाथरूम में पूरी पूरी ने पण सर दादा होती बात नहीं करते. हम छोटे भागरियों को फेंके मारो पारा खोल खोल कट થઈ ગયેલો ના બંધા લેખા માં ચડી ગયેલા મારા પોતે. તમે કઈ ગાંધી જિંદગી ધોધારી થઈ જશે બિચારાની. આને ક્રેડિટ કાર્ડ ના અપાય. अच्छा, दोनों कोई गीत गावन तुम्हारा. नमस्कार सर, हम फालतू बैंक से बोल रहे हैं, क्या आप हमारी राजकुमारी सोना वचना बोल तो आपको गीत गावा दे. सोना राजकुमारी 12:30 મિનિટનું ગીત છે સાહેબ અને 147 વખત સોના સોના પેલો સુઈ જાય. વચ્ચે તો બોલવા ના પાડી તમે એને. તમે કોઈ બીજી ભાષામાં વાત કરો એમ જોડે. नमस्कार सर, हम फालतू बैंक से बोल रहे हैं, क्या आप हमारी जमा है ना क्या लाग्यो क्या भाई भाई जी में लाग्यो वो हम वो नदी ना किनारे भरे भाई चीनिया जोड़े धींगे धींगे केम कर उपदेश आपो तमे. नमस्कार सर, हम फालतू बैंक से बोल रहे हैं, क्या आपको लोन चाहिए? माया कौन? धन वैभव यश माया. I think warning in progress. अच्छा ये तो भले करता अच्छा बोल पहला हमारा सवाल में जवाब आप बोलो सर अंगम गलितम फलितम मुंडम वचन विहीन जातम तुंडम बुद्धो याति घृत्वा दंडम सत्विन मुंचति आशा पिंड આનો અર્થ શું થાય ફરી બોલો ના ફરી ના બોલાય એક જ વાર બોલાય ફરી બોલાય કે મને આવડતું તો આટલું આવડતું બોલી ગયો તો નહીં આવડતું તો નથી લેવો आंसरिंग मशीन की मैं बात कर रहा हूँ नमस्कार सर हम फालतू बैंक से बोल रहे हैं क्या आप हमारी कंपनी का क्रेडिट कार्ड लेंगे नमस्कार શું તમે વિનય વિનય સાથે વાત કરવા માંગો છો તો એ દબાવો શું તમારે ક્રેડિટ કાર્ડ આપવું છે તો બે દબાવો લાઈફ ટાઈમ ફ્રી ક્રેડિટ કાર્ડ આપવા માટે 9 દબાવો 8 વખત દબાવ્યું છે તારો કોલ કેન્સલ અને સૌથી ભયાનક તમને બીજો એક આઈડિયા नमस्कार सर हम लोग बैंक से बोल रहे हैं क्या आप हमारी कंपनी का क्रेडिट कार्ड लेंगे नमस्कार હું ટેલિમાર્કેટિંગ એસોસિએશન અમદાવાદથી બોલું છું બોલો હું તમારી શું સેવા કરી શકું સાહેબ તમારે ક્રેડિટ કાર્ડ લેવું છે ધીમે બોલો તમારો અવાજ સાંભળ્યા પરથી લાગે છે કે તમે બ્લડ પ્રેશરથી પીડાઈ ગયા છો તમારા હાર્ટ રેટ વધી ગયા છે ટેલિમાર્કેટિંગ એસોસિએશનના ડોક્ટર રાજ રાવળ હવે તમારી સાથે વાત કરશે અને તમને કઈ હોસ્પિટલમાં દાખલ કરવાની કહેશે નથી જવું મારા બાપા વડે તમે યાર સીધો હોસ્પિટલમાં દાખલ કરી દેવાની વાત કરો તમે આનો સૌથી ભયાનક છેલ્લો ઉપાય કહું તમને नमस्कार सर फालतू बैंक से बोल रहे हैं क्या हमारी कंपनी का क्रेडिट कार्ड लेंगे 1 मिनट આ લાસ્ટના કાન ટુકડા અલગ અલગ પેક કરવાના કીધા કરો ભાઈ તમે શું કહેતો હતો તું સાહેબ મોબાઈલ કહેતો હતો ક્રેડિટ કાર્ડ એક ટકી આંગળી બહાર નીકળી જાય ઉભી અંદર છરાબરા ધોઈ નાખ લોહીના ડાઘા લઈ નાખ શું કહેતો હતું એ માથું રહી ગયું છે કહેતો તો બોલ કઈ નતો કહેતો સાહેબ હું તો મૂંગો છું માનસી બાપને કહેવાય નહીં તમે પેલા કાન ટુકડા કર્યા મારે ફિનિશ કરી નાખો બહાર નહીં આપવા તમને ક્રેડિટ કાર્ડ આવા ભયાનકમાં ભયાનક ઉપાયો તમે અજમાવી શકો છો આનંદ કરી શકો છો મજા કરી શકો છો કારણ કે આપણા ફીસમાં જતા નથી આપણે કઈ ટેન્શન લેવાનું નથી તો આમાંથી મજા લો અને છેલ્લી વાત તમને કહેવા માંગુ છું કે દાંતમાં સાવ ઝીણું કોતરું સરવાય છે દાંતમાં જો સાવ ઝીણું કોતરું સરવાય છે એ પછીથી વાતની તો વાટ લાગી જાય છે દાંતની અંદર જો કોતરું ભરાઈ ગયું સાહેબ એ પછી તમે વાત ના કરી એવું બધું થાય છે રાજભાઈ ને મને કે કાલે તમે 3:30 આવી જવું જગ્યા પછી મારે વાત કરવી હતી તમને કે પછી નીકળ્યા 3:30 ફાવશે એટલે દાંતમાં જો સાવ ઝીણું કોતરું સલવાય છે એ પછી તો વાતની ત્યાં વાટ લાગી જાય છે ને વાળ ધોળા થાય ત્યારે વાત એ સમજાય છે વાળ ધોળા થાય ત્યારે વાત એ સમજાય છે આ કલર કરેલા જાઓ કે વાળ ધોળા થાય ત્યારે વાત એ સમજાય છે બોસ જ્યાં ત્યાં કૂદવાથી પેન્ટ ફાટી જાય એટલે ગમે ત્યાં કૂદતા પહેલા ધ્યાન રાખજો થેન્ક યુ વેરી મચ ખૂબ ખૂબ આભાર
Thank you, Vinay sir. Thank you, Vinay sir. Now, I would like to invite Dr. Raj Rawal sir, the President of Gujarat Tele-Medicine of India, for a vote of thanks.
Hello. Thank you, Vinay bhai. Give a big cheers. Huge round of applause. બહુ મજા આવી વિનયભાઈ બેઝિકલી શું કહેવાય એમના જોનર ઘણા બધા છે એટલે તમારે એમને એકવાર જરા ગાડી પેલી આમ શું કહેવાય અભિષેક શર્મા બી હમણાં તો ખાસો ફ્લોપ ગયો હતો એટલે ઘણી વાર શું થાય કે એકવાર rhythm આવી જાય ને પછી તમારે એ સદી થઈ જાય, ડબલ સદી થઈ જાય, ટાઈમનું કંઈક પેલું જ ના રહે. હવે એ ફોર્મમાં આવી ગયા હતા એટલે હજુ સાંભળવો તો હવે ફોર્મ હવે ચાલુ થશે કારણ કે નાઉ ઇઝ ઇન rhythm. But anyway, I think we have a special session of Vinay bhai. Well, thank you Vinay bhai for sparing time. So I think finally we end our today's program. Before ending, I think I would like to thank lot many people. First of all, જ્યારે કોન્ફરન્સ શરૂ કરી ત્યારે એટલે જ્યારે વિચારવાનું શરૂ કર્યું, I think just before 20-25 odd days we have started thinking about conference કે કરવી હતી conference કે let us start doing a state conference of TSI. તો પહેલો તો હું થેન્ક્સ કહીશ મારી આખી ઓર્ગેનાઇઝિંગ ટીમને. So big cheers.